Aroi-Estrp teaching course. Hope you all have a good time. Let's make today more impactful than yesterday. Ganesha to begin his session. Thank you.
Good morning to all, and at the outset I would like to thank ISRO and ARY for giving me this opportunity once again to be amongst you, and it's very nice to come back to this town, Patna, after a very long time. We will start this presentation by taking some 5 questions. So I would like all of you to scan this, enter the code, are you ready? Shall I move? Okay. In SBRT, the dose per fraction is much large compared to the conventional fractionation. Such large doses could be delivered because of large alpha beta for tumors, small alpha beta for tumors, higher energy that we use, greater than 15 MV beams are used, better geometrical sparing factor, and better skills and training of personnel. We'll see the answers for these during the presentation. Okay, there are 10 for better, 10 or 12 for this better geometrical sparing factor. Now let's go ahead. Which of the 5 R's of radiobiology has a relatively more important impact on the cell killing mechanism in SBRT? Repair, repopulation, redistribution, reoxygenation, radiosensitivity. Okay, that's interesting. We will see the answers. I have a TPS with a pencil beam algorithm. I can start SBRT after taking extra care in the beam data collection and following extended validation of the beam data. I have only a TPS with only pencil beam calculation algorithm. I can start SBRT services after taking extra care in beam data collection and extended validation. No, never. Yes, you can do. Yes, if my SBRT team is experienced. Yes, if I buy additional QA. Yes, if I acquire the planning license from the vendor, special planning licenses from the vendor. I hope you got the question. Supposing in your clinic you have got a TPS with only TPS pencil beam algorithm, whether you can start SBRT, yes or no? Yes, with if the SBRT team is experienced. Yes, if I buy additional QA, and yes, if I acquire planning licenses. Thirteen say if I buy additional QA. In SBRT planning, what is the recommended acceptable grid size resolution which, if exceeded, could result in significant dose calculation errors? 0.25 mm, 2 mm, 5 mm, Depends on the field size, depends on the treatment site. What is the grid resolution exceeding which there will be dose calculation error? 0.25 mm, 2 mm, 5 mm, depends on the field size, depends on the treatment site. Fine. So we'll see the answers during the presentation. Can we start the presentation? So next 40 minutes or so, I'll be talking about the SBRT definition, radiobiology, physics, and the technology. Mostly regarding the physics, I'll be talking about what are the commissioning, the things that go behind the screen. Those are the things I will be concentrating. Definition of SBRT. SBRT is all about precision conformality, wherein we deliver a dose of 15 to 60 gray in 1 to 5 fractions to the target volume. And in contrast to the conventional radiation therapy, we see a steep dose gradient and a sharp dose fall off in all directions as we move away from the target volume, thus minimizing the damage to the normal tissues. The definition of SBRT, the term SBRT did not appear in 1994, but for the first time it was in 1994 that SBRT was tried at the Karolinska Institute, the Ingmar Lax team, and they used 8 non-coplanar individually shaped beams to try in their patients. And subsequently in the next year in 1995, they came out with the results for 31 patients. And the most important thing about this publication is that they ensured that the central part of the target volume received 50% dose more than the prescription dose. Coming to the radiobiological principles of the SBRT, now we know that at low dose per fraction, that is at 2 gray or so, we have a small window of opportunity. That is, the normal cells repair more than the tumor cells. The tumor cells do not repair damage at the low doses as well as the normal cells do. So, if we exceed that dose at very high doses, then the late reacting normal tissue cells will prevent us from delivering very high dose per fraction. So at 2 gray per fraction, there is a window of opportunity that we exploit by fractionating. By fractionating, we widen that gap, and that's the principle in the conventional radiation therapy. But in this graph, we assumed one important thing, that the dose to normal cells is equal to the dose to tumor cells. That is one false assumption in this graph. The major advantage of 3D CRT, particularly in SBRT, is that the dose to normal tissue is kept much less. It is not the same dose that the tumor cells are receiving. So the effective dose to normal cells is much less than that to the tumor. So the ratio of the effective doses to normal cells to that in the tumor cells is what is called as the geometrical sparing factor. The geometrical sparing factor F, as called by C.J. Orton, for 3D CRT is less than 1, but for SBRT it is much less than 1. Even at a modest F factor of 0.8, the window of opportunity for us extends from 2 gray to 10 gray. So earlier we were not able to deliver more than 2 gray per fraction, but now we are able to deliver more than 2 gray up to 10 gray per fraction. What does this mean? We can safely deliver much higher doses, provided it is highly conformal therapy. 3 things are to be kept in mind. We have to be highly conformal, highly accurate. with reduced size of PTB margins and thereby reducing the volume of normal tissues in the high dose region. So provided these conditions are met, then we will be able to increase the dose per fraction. So the geometrical sparing factor is the main contributor for increasing the dose per fraction. Now, in conventional radiotherapy, we know that that cell deaths are caused by the DNA double-strand breaks. So, if only that DNA double-strand breaks are the mechanism involved in the cell deaths, even in SBRT also, then in that case we would require a dose of 70 gray in order to reduce the surviving fraction to 10 power minus 8. However, in our clinical practice, we have seen that even with the 15 to 60 gray delivered in 1 to 5 fractions, we are seeing excellent results. So that is not sufficient to explain this phenomenon, supposing if only the DNA double-strand breaks are responsible for the cell deaths. That means that there must be mechanisms other than the DNA double-strand breaks involved in the SBRT to see the kind of efficient tumor control that we are experiencing with SBRT. So one of the most important mechanisms of this additional cell death secondary to additional cell death that we see in SBRT is due to the secondary radiation-induced vascular damage, which significantly contributes to the remarkably high efficacy of SBRT. So there are vascular changes following high dose that we deliver in SBRT. The functional vascularity in tumors decreases within few hours after delivering 10 to 15 gray. Such a rapid decline in the functional vascularity results in the death of endothelial cells, leading to extravasation of plasma protein, which results in increased interstitial fluid pressure and collapse of fragile tumor vessels. So following these vascular damages to the it leads to indirect cell death. That is, when tumor vasculatures are injured, then the blood flow is disrupted and the intrinsically hypoxic tumor microenvironment becomes even more hypoxic, leading to depletion of ATP and accumulation of tumor necrosis factor. So the tumor cells, particularly when they are irradiated, they will not be able to survive this highly hypoxic tumor microenvironment, and they become nutritionally deprived. They cannot survive this hypoxic, nutritionally deprived tumor microenvironment, and they undergo apoptotic and necrotic death. When we think that the vascular damage is one of the most important reasons for the additional cell death that we see in SBRT, there have been papers which tell otherwise also. That is, these papers claim that it is the vascular normalization, not the vascular damage, that matters in SBRT. That is, vascular endothelial growth factor, VEGF, is a major driver of tumor angiogenesis, we know. Anti-VEGF monotherapy has been aimed to control the tumor by starving them of blood vessels. So that has been tried. However, the clinical trials using anti-VEGF monotherapy have been largely negative, particularly in solid tumors. But when anti-VEGF monotherapy has been combined with chemotherapy, that has been shown to improve the survival rates in patients. So these seemingly paradoxical results can be explained by this theory of vascular normalization, the vascular normalization hypothesis. That is, anti-VEGF therapy changes the tumor vasculature to a more mature phenotype, resulting in reduction of tumor hypoxia and interstitial fluid pressure reduced. which in turn lead to an improvement in the metabolic profile of the tumor microenvironment and improving the efficacy of radiotherapy. The other mechanism, possible mechanism that can improve the SBRT, that increases the cell death in the SBRT is in conventional radiation therapy, immune cells are repeatedly assaulted and they are eliminated. However, in SBRT acts more like a protective mechanism for them. They may be less detrimental to the anti-tumor immune lymphocytes, and they thus promote anti-tumor immune processes. Thus, high dose of irradiation of tumors increases the anti-tumor immunity by acting like something like an in situ vaccination. However, we must remember that SBRT can act like a double-edged sword when it comes to anti-tumor immunity, in the sense that it also promotes the immune escape pathways of tumor cells and they can result in suppressing the anti-tumor immunity. Do the 5 R's of radiobiology have any role to play? Perhaps reoxygenation has something to do with deciding what is the optimal gap between the two fractions. There is significant reoxygenation happens in tumor 15 to 20 gray, following 15 to 20 gray of radiation, while reoxygenation occurred 3 days after 10 gray. So, reoxygenation may hold the key in deciding the optimum interval between the fractions. But it is the redistribution which may possibly play a role in the increased cell death. That is, SBRT high doses can lead to cell arrest. That is, the cells get arrested in the phase in which they are irradiated, and they cannot further move ahead in the cell cycle, and they undergo what's called as the interphase cell death. So the changes in the tumor microenvironment further enhance the cell cycle arrest, thus enhancing the cell death seen in the tumor cells. Moving on to physics, SBRT services in a clinic, we know that these are highly advanced techniques, and any attempt to start SBRT services in a clinic, there must be a lot of behind the screen activities that must go before these services are started in a clinic. So there must be detailed planning, methodological preparation, and extensive testing must be done, and the requirements as regarding the time and also the budget may be quite demanding. We should have resources on every front regarding the instrumentation. We should have redundant radiation detectors suitable for small fields, and the routine ones that we employ in the conventional RT are not sufficient. We should have multiple detectors suitable for small fields along with the reference class electrometer. Appropriate end-to-end phantoms must be there, and we must have a quality control device to establish the radiation isocentricity and beam alignment verification, besides having other QA phantoms. For the simulation planning and treatment, we should have in the clinic the capability to characterize and quantify the internal anatomical changes, that is, with the respiratory motion. We should have multimodality image fusion capability, and when it comes to patients who have already received radiation therapy, the clinic should have the capability to calculate, display, and evaluate the composite dose for these patients who have already been treated by radiotherapy. Suitable LINAC-based delivery system with image guidance devices for target localization and verification, including the motion management technology, should be available. Administrative support, I will just point out only 2 important factors. The administration should support independent third-party peer review for the SRS SBRT program in that clinic, and also it should facilitate on-site proctoring of the first treatment of SBRT. So administration should support these kind of activities. When it comes to the medical physics responsibility, the physics responsibilities, if you see, you can clearly group them into two different headings. One that go prior to commissioning of or before we actually establish the SBRT program, and then on a day-to-day basis for treatment planning of the SBRT patients. So initially what it goes, customer acceptance testing and commissioning of the system, the process commissioning, implement and manage QA and establish a comprehensive checklist. These things go prior to start of the treatment SBRT program, and then physicists will play important role, of course, in performing, supervising the treatment planning process, review of the final plan for accuracy and deliverability, and physicists must be available throughout the entire process. Commissioning consists of two aspects: equipment commissioning and process commissioning. Equipment commissioning, physicists must establish, first of all, the safety of the equipment involved, and also they should be thoroughly evaluating the geometrical accuracy that can be achieved with the imaging and the treatment components that they have in their clinic. So they should thoroughly evaluate and make the results known to everyone in the clinic. Small field beam data measurements, for those of you who do not know about this is a very, very critical step in the entire SBRT commissioning process, and a lot of importance has to be given. Physicists will have to be provided with adequate resources and adequate time in order to perform these small field beam data measurements, and a daisy chain method must be followed using multiple detectors. After completing, this step is so critical that it needs multiple validation. After completing the beam data measurements, it's a wise thing to do. It's wise thing to do comparison by comparing with the data from other machines of similar nature. You have to compare your values, what you have measured in your clinic, especially the data for like PDD 10 centimeter depth, and also the output factors for very small field sizes. That shall not be any major deviation. So comparing these will help you in avoiding any type of gross errors, which unfortunately have happened in Western countries. Due to these gross errors can happen if proper instrumentations are not used, like inappropriate detectors or incorrect setup can lead to gross errors. Equipment commissioning, we have to commission the immobilization equipment. As regarding we have to evaluate the accuracy and the precision. We have to characterize the beam attenuation property of the immobilization equipment, and also we have to find out what are the surface dose characteristics, how are they affected by the immobilization equipment. The treatment planning systems should be thoroughly evaluated for image fusion accuracy. What is the kind of accuracy that you can achieve with for image fusion? What are the accuracy of the small field dose calculation accuracy for the couch attenuation, effect on the surface dose, the effect of the couch on the surface dose, and also the dose calculation accuracy overall of the treatment planning system. And also motion management, end-to-end testing using a dynamic phantom to evaluate accuracy and precision. Finally, after doing all these things, one has to prepare a comprehensive commissioning report, a clear summary report mentioning what all that you have done in these commissioning work, what were the results that you have obtained, and what are the known limitations of the system that you are having, whether it is imaging or dose planning or whatever it is, what are the known limitations. The commissioning report should clearly mention, and also limits for clinical implementation. For example, like the couch isocentricity, make known to everybody. And also what is the minimum field size that you can use at the time of treatment planning. Once again, you have to determine and make it known to everyone in the clinic. And importantly, make a table of baseline data. This is very important at the time of commissioning. Baseline data, make a table so that it can be referred to for ongoing QA. Development of a QA program. Following this commissioning, next one should develop a QA program for the immobilization devices, the ancillary systems for imaging and motion management, the treatment planning systems, treatment delivery machine. You develop a QA program and form a quality assurance manual. The process commissioning is about, that is equipment commissioning. Process commissioning is about how you are going to do it on a day-to-day basis, the technical process. How are you going to execute the SBRT in your clinic? So this process commissioning, how you are going to perform, this one has to be done prior to the first treatment by way of developing SOPs for patients, mentioning the patient selection criteria, simulation. In the simulation, the scan area, slice thickness, everything should be mentioned in the SOP. Motion management, planning, all these things should it should be mentioned in the SOP. Special consideration when it comes to re-irradiation, then it has to be clearly mentioned that how you are going to do the planning process. And calculation grid resolution should be 2 millimeter or finer. Most often finer than 2 millimeter may not be possible, only 2 millimeter will be possible. Definitely it shall not be more than 3 millimeter, but 2 millimeter is the recommended grid size for dose calculation. You should also mention here coverage, fall off, indices, independent dose calculation check, everything should find a place in SOPs. Pre-treatment QA check, how you are going to do and when you are going to do, everything mentioned in the SOP. And clearly describe what kind of image guidance method, including the tolerance values that you are going to follow. And finally, design the checklist. The process commissioning also includes the training. Training is a very critical parameter in the SBRT program. And it should be initial training followed by ongoing periodical training program also. And the credentials must be established by way of proper documentation that these persons involved in this SBRT program have been properly trained and they are qualified for executing the SBRT treatments. So the credentialing should be properly documented. And also end-to-end testing. Do the dry runs of the entire process from beginning to end. Observe what are the type of problems, bottlenecks that you come across. Take notes and then try to make fine-tunings of the SOPs if necessary. Coming to the quality assurance, 3 aspects to it: equipment-specific quality assurance, patient-specific QA, and process-specific QA. Equipment-specific QA, relevant reports, follow the relevant reports. There are multiple reports, TG 142, medical physics practice guidelines, 2A, 5A, TG 135, TG 145. Follow these documents in order to develop your equipment-specific QA program. The baseline performance values that we had initially done at the time of the commissioning, that should be referred for the ongoing QA program. CT should be evaluated at least annually. Every year the CT used in the SBRT should be tested annually. Coming to the patient-specific QA, verifying that the approved treatment plan can be accurately delivered, that is the patient-specific QA. It's just not only the dose measurement in the LINAC room. We have to check everything. And for cone-based, perhaps this step can be that there is no need for measurement if it is cone-based SBRT. Institution must provide appropriate instrumentation for doing this patient-specific QA, and clinical services shall not be initiated if appropriate instrumentation is not available. Procedure-specific QA is ensuring that what we mean by procedure specific QA is that having SOP is one thing, but following it in the clinic is another thing. So whether you have followed the SOP and performed the SBRT treatments, that is what we call it as the procedure specific QA. So ensuring that SOP documents are consistently followed, the staff are well trained, and the staff are adequate, ensure that that is also the procedure specific QA. Follow-up actions are taken for any incident and near misses. Staff without prior experience must perform a minimum of 5 procedures under the expert supervision before they can be entrusted with the SBRT responsibilities. Coming to the technology, I will not go much into the details, but we know that regular C-arm Linux are used, either regular or high definition MLC. These Linux can have. Couch with 6 degrees of freedom movement are highly recommended for if you are attempting at SBRT. Imaging should have KV CVCT and 4D CVCT. Surface guided radiotherapy, intrafraction monitoring of motion by surface guidance or KVR by Calypso, and it's preferable to have FFF mode, which will greatly reduce the treatment time. Tumor therapy, we know about these tumor therapy. It uses a helical method to deliver the beam from 51 projection while the couch moves continuously. It employs a 6 MV LINAC, binary MLC 32 pairs, each leaf 6.25 mm wide, take about 30 seconds to open and close. And slice thickness 2.5 or 5 centimeters. It has got integrated onboard MVCT and KVCT, sub-millimeter accuracy in the couch positioning, and dose rate is either 850 or 1000 centigrade. CyberKnife, it has undergone many technological improvements since the time it was initially introduced. The LINAC is, as we know, is mounted on a robotic manipulator with 6 degrees of freedom, and the dose rate is 1000 mu per minute. The target is tracked through real-time tracking using a pair of stereotactic X-ray system and an optical motion monitoring system. MR guided radiotherapy is a newer technology, and it monitors the organ motion in real time, and it has got the ability to adapt the treatment if needed. Increasingly used for SBRT, particularly in abdominal tumors, and other benefits are being investigated like functional imaging and MR guided radioimmunotherapy. So what's the right choice for SBRT? Is there any particular technology which is most suitable, which is most recommended? No, the choice of SBRT modality should consider multiple aspects: cost, efficiency, accuracy, robustness, limitations, motion management, IGRT, and intrafraction motion. There are, with each of the modality, with each of the technology, there are some minor disadvantages, but these disadvantages can be overcome by having the right choice of personnel, and well-controlled policies and procedures can overcome these modality disadvantages. There is no absolute criteria to define which modality is suitable for SBRT treatment. Just points to remember before closing the presentation. One thing that we have to know is that the dose is due to secondary electrons. A photon is interacting at a particular point, and then the energy is transferred from the photon to a secondary electron. Now this secondary electron is the one that is ultimately responsible for the dose that we are interested in. And this again secondary electron from the point of interaction can traverse few millimeters to few centimeters, what we call it as the range of the secondary electron. This range of the secondary electrons is very critical, and especially in SBRT. We keep talking about small field dosimetry again and again, like in the initial slides I kept talking about small field dosimetry. So why small field dosimetry? Why are we bothered so much about small field dosimetry. It's because of this range of the secondary electrons. As we see here on the right hand side, 6 MeV photon on an average transfers about 3.86 MeV to the secondary electron. Now this 3.86 MeV secondary electron can travel 1.9 centimeters in muscle or about 7.6 centimeters in lung. Now this is quite a significant range, and when the field radius is smaller than the range of these, the field radius, when it is smaller than the range of the secondary electrons, it poses tremendous difficulties in the dosimetry of those beams, which we normally don't come across in conventional radiation therapy because the field sizes are quite large. But here in SBRT we are using small fields, and in these small fields the range of the secondary electrons can be larger than the fields that we are employing, and it poses tremendous difficulties. And small fields other than this range of secondary electrons, they have got other difficulties also. So that is why the small field dosimetry is very important and very critical if you have to ensure a good SBRT program. And similarly, these also have importance in the dose calculation algorithm. Why are we keep talking about the dose calculation accuracy of DPS algorithm? That's because type A algorithm like the pencil beam. Remember my question that if you have got only pencil beam algorithm, don't start SBRT program if you have got only pencil beam algorithm. Doesn't matter that what kind of additional QA you have got, what kind of accuracy with which you measure your data. With pencil beam algorithm, SBRT program should not be started because type A assumes electrons deposit all energy locally, which is not the case. In the patient, electrons take the energy away from the interaction site and deposit somewhere else. So we are not modeling in that type A algorithm. However, type B accounts for these in an approximate way, so they are good, like the convolution superposition algorithms, and the type C accurately accounts like the Acuros XB in the Eclipse and also the Monte Carlo in Monaco. But they have also certain limitations. So if you are practicing SBRT, it's a good thing to know about the limitations of these algorithms. And this is what actually it can happen. If you look at these, the dose volume histogram calculated by the Monte Carlo MC and the triple C collapsed cone algorithm, they are more or less similar, and they are the ones actually happening inside the patient. But even AAA can fail in this type of centrally located target volumes inside the lung. So that is why if you do not have the right kind of algorithm, SBRT program should not be attempted. And when it comes to beam margin and beam penumbra in conventional RT, we always take a margin of about 5 to 7 millimeter, which is of the order of the beam penumbra. But when we use like that, the dose fall off outside the target is very slow. But in SRS and SBRT, we take the beam margin close to 0. Now usually 0, or at the most it is 2 millimeter, not of the order of the penumbra. But it results in a heterogeneous dose within the target volume, and the dose fall off outside the target is fast. So penumbra has an important role in prescription, and it has to be modeled perfectly if we have to have accuracy in our SBRT program. When it comes to treatment planning, coplanar beams versus non-coplanar beams, it is something similar to having, compare spokes of a cartwheel with the spokes of an umbrella. So spokes of a cartwheel, all the central axis of the beams are in the same plane. That's why it's called as the coplanar. The central axis are in different planes. They are called non-coplanar. So non-coplanar beam setup help you in achieving sharp dose gradient, but they are efficient for small beams. When your field size are large, then the efficiency will be lost. So for small beams, going for non-coplanar beams will help you in achieving a very sharp dose gradient. Restrict the entry dose to less than 30% of the cumulative dose. 5 mm MLC resolution is more than adequate, and remember, higher the beam energy, larger will be the penumbra. Coming to dose prescription and plan evaluation, it can vary and it can depend on SBRT technology, equipment used, TPS algorithm, training and institutional protocol. You see how the doses can vary depending on where you are prescribing. Like the one on the left, the blue color, the target dose is 60 gray, prescribed to the isocenter, peripheral dose is 57 gray. So this is the coldest treatment. The one in yellow, the dose is prescribed on the periphery, but the periphery receives 80%. So isocenter dose is 75 gray. It results in an intermediate treatment, means intermediate dose. 60 gray prescribed to the periphery of the target where it is receiving 60%. The target, just a couple of more slides. The target isocenter dose is 100 gray. So it results in the hottest treatment. So dose prescriptions can differ. When we talk in terms of percentage, it's quite possible to err inadvertently. Plan normalization, dose normalization, they are quite different. Please note this. Plan normalization is different from dose normalization. When the plan is normalized at one point and the dose is prescribed at another point or another isodose line, possibility for error is more. So, very important, your plan evaluation is never complete without evaluating dose distribution in centigrade. Make it a point that your plan evaluation includes seeing the dose distribution in centigrade. Plan evaluation must include assessing the high conformality, hotspots, whether they are located within the GTV, they should not be located outside of the GTV. The dose fall off, ensure that the dose fall off is fast outside the PTV and uniform in all directions. Follow these RTOG guidelines. There is what is called as the dose gradient index. Make it a point that this dose gradient index is evaluated and recorded on the paper. Variable, it is variable as a function of target size. Target coverage, OAR constraints and other dose metrics should be evaluated. I will not go into the detail, but before you take the plunge into SBRT, do assess all these points. To summarize, SRS SBRT services are highly specialized clinical services. Provision of these services must follow a structured approach with very clearly defined roles and responsibilities, procedures and action levels. There must be a commissioning report, and this commissioning report should bring out the key results and also identify the known limitations of the setup that you are having in your clinic. Independent validation of the model and the machine calibration is highly recommended. That is, third-party audit is a very good thing for ensuring quality in the clinic, and on-site review and proctoring of the first procedure is highly recommended. Thank you very much. Time to take questions.
Thank you for informative talk, sir. So what is the advantage of DCAT? Actually, DCAT, it takes more time compared to other one. So is there any case, means particular case we can do DCAT, or and all other case we will do DCAT?
What is
DCAT, dynamic conformal arc therapy. Yeah. So is there any particular case we have to do DCAT, or all case we have to do? So is there any advantage on particular case? So because it takes more time to optimize.
For optimization?
Yes, yes, sir.
That is fine, because we are bothered about the treatment time only. On the table, the VMAT will take less time.
So, no, my question was, sir, in single target or multiple target, DCAT will be advantage, or all case we have to do? We can do?
We can do.
And second question also, sir. So most of the center, they use, from GTV margin, they use 0 mm, no margin, 1 mm, 2 mm. So what criteria actually you follow? If we ask to employees, so no margin you give, So why you no margin? So actually they told actually this is debatable topic. So
This
what
is,
criteria you follow, sir, at
yeah,
your
this
center?
is purely a, you know, decision by the physician.
Yeah, actually,
That what margin,
yeah, for physics,
it can vary from one clinic to another clinic.
yeah, for
The-
medical physics purpose, sir. So zero margin, actually, it is very tight margin. So I am asking what criteria you follow actually, sir, at your center.
Right now, I am not working in clinic, so I cannot
Yeah.
say. But I think it's purely a physician choice.
Thank you.
Very nice and informative talk, sir. Thank you. Sir, my question is, what is your opinion regarding the time gap in fractionated SBRT? What should be the ideal time gap? Or it depends on the dose we deliver?
I think it depends on the dose. It depends on the tumor type also.
Sir,
So we have to say, and what is the dose per fraction that you are using?
sir, like if we consider it is more than 10 gray, then what should be the time gap? If it is less than 10 gray, so what should be the ideal time gap? Is it 24 hours or?
No, Dr. Yungi?
Time gap between fractions.
Between
Yes,
fractions.
Yes.
That I wanted to know.
No, I mean in an SBRT treatment.
Fractionated SPRT treatment, what
Yes.
should be the ideal time gap between two fractions?
I think that usually between fractionated treatments, the time gap is usually 3 days a week is your usual fractionation schedule. Now, I'm pretty sure that there have been protocols followed where you are doing everyday treatments, and there are situations where you give once a week treatment. Now, these are usually based on acute side effects. But from the radiobiological perspective, I think a 24-hour time gap should be enough for redistribution of cancer cells. Yeah.
Just to add on, what Dr. Enlil is saying regarding the gap between SBRT fractionation. See, radiobiologically, if you see the repair of the sublethal damage, especially for late reacting tissue, takes much more time as in early reacting tissue, and it is seen that sometimes the complete repair takes around 24 hours. So there are some evidence, especially in prostate cancer, which have shown that if you give alternate day treatment, then you have less late reaction as compared to when you treat every day, because of the difference in the repair of the sublethal damage, especially for late reacting tissues.
Thank you so much.
It's mainly an acute side.
Sir, what is your view on the patient-specific QA in the resolution or the detector field size, or what is the minimum criteria to perform patient-specific QA?
What is the minimum?
Criteria for the patient-specific QA in such treatment, advanced techniques. If we are doing any fluence measurement, so what minimum field resolution we required from the detector point of view?
I think, see, first we have to measure the dose. Absolute dose we have to measure separately, and also regarding the planar dose measurement, the best possible resolution that you have got, it is the best thing that you can do, especially when you are delivering this kind of high dose per fraction. So plan well in advance, so you cannot purchase later on. So if you are going to commence the SBRT, try to go in for the best in the market, the best QA device in the market, which has got the best resolution.
Okay, thank you, sir.
Thank you, sir. Taking dosimetric factors into the account, like conformity index, heterogeneity index, and other index like gradient index. So SBRT using VMAT plan or IMRT plan, which is better, you find, and in what context?
The BMAT will obviously result in less time and less MU as compared to IMRT. So probably it should be VMAT. But then there are limitations. Like, we have to try. The best thing would be do both and then evaluate that what is the best.
Which is the best. Because being a radiation oncologist, we are always considering the factors of OAR, that how you can, have the minimum of saying that.
A good practice will be to do both the planning and compare both the plans and then judge between that which one will be better to deliver
for that particular patient.
from the delivery point of view.
Thank you.
Ganesh, I just want to know how far we are kind of confident on the OAR constraints in various kinds of publications and recommendations like Timmerman, like Quantec. Everybody has some kind of different OAR constraints. So where we are going, what is your impression, whether these OAR constraints are holding ground or clinical studies versus the constraint? What is the latest about this? Because sometimes it is very difficult to believe one constraint from the other, which are sometimes quite different in three fractions or 5 fractions.
I think that is why at the time of initial process commissioning, we have to decide on this after consulting all the published results, discuss among ourselves, and then see.
No, but what does the literature says? Well, we will look into the literature to find out what, because so many recommendations are there. How to decide which one we should follow?
I think for the moment, Dr. Anand, we will have to follow the compiled recommendations of, for example, the UK.
But they're quite variable.
They are variable, and I think that they're partly empirical as well. Yeah. But they are often based on some level of reported results.
Because
or what
see
is
the
being
Timmerman, he is quite liberal. Andrew has any comment to offer? Because I don't know myself what is the answer.
Yeah, so I think it depends quite a bit on which constraints you're focused on. So I threw just a moment ago a couple extra slides into the afternoon clinical session that we're going to do in SBRT, and I have a section on, for instance, chest wall constraints that are used during SBRT and show some of the variability in the dosimetric criteria and the issue of we call it collinearity, which is to say the fact that if I pick V30, V50, V60, those all have a relationship because of the type of dose distributions that we're generating here. And so technically any of those constraints can work so long as you understand which one and what the thresholds are that are corresponding to a relevant endpoint. So, as you mentioned, Dr. Timmerman has obviously for many, many years espoused the idea of highly aggressive treatment because the alternative is in many cases tumor failure. And fortunately, I think he's very honest about the fact that in some situations, his aggressiveness has led to some toxicity. That first publication that was done many years ago showing the central toxicity, I think is a very crucial sort of commentary on the fact that we can be aggressive, but it has consequences. And so I think there are definitely spectrums of physicians that are more comfortable being aggressive as he is, and some of us that are more conservative. And I think the constraints have to reflect the fact that there's individual risk tolerance amongst both physicians and patients. And in some cases, a very conservative physician, like let's say me, if I'm presented with a situation where a patient wants to be very aggressive, if I show them the data, they can sometimes help me make a decision on those constraints that is comfortable for them, even if it isn't perfectly comfortable for all the physicians, even at my own institution. And so I think understanding the variability of the constraints and the issues associated with the selection of a given threshold or a given risk tolerance is unfortunately complicated. And I don't think there's a perfect answer. I don't think we're all like Bob. Bob Timmerman is a very aggressive physician and very much wants to treat people with curative intent regardless of what happens down the line. And I think that isn't a universal accepted a position for physicians in general. So it's a great comment, and I think that variability does underlie some of these constraint variations.
I think last question. Yeah.
Even though radiobiology is not very much clear regarding the SRS treatment or SBRT treatment, Again, sir is saying that in prostate we have to see things that the alternate day treatment. But in SBRT we have prescription method. Basically, there are two different things. That is isocenter based or the isodose line based. But we have giving very tight margins. So I have a question: what gradient index should ideally we have to follow for the SBRT or SRT treatment? Basically, what should be most ideal?
No, gradient index, there is no any deviation from what has been described. It is, the gradient index is volume of volume receiving 50% of the prescription dose to the PDV volume. So that is, there is no change in
No,
that.
I think what he's asking is that is there a recommendation of the value of the gradient index?
Oh.
Like, does it have to be above or below a certain threshold?
No,
Not,
we
not-
only follow the RTOG, that those published values which vary according to the target volume, not according to where you have prescribed your dose. So it is according to the PDV volume only.
Right.
RTOG 0915 has the gradient index values for Linac, Siam, Linac as well as CyberKnife.
CyberKnife.
So you can just
Yeah.
follow that with respect to the PDV volume with respect to the gradient index.
Right. So
And you have minor and major deviation. If you are below the minor deviation, you should be okay. None, minor and major.
thank you. So we'll move over to the next talk by Dr. Hope.
Thank you, Dr. Ganesh. Our next session is Frameless Image-Guided Radiation Therapy and a Stereotactic Radiotherapy by Dr. Hope. We welcome you, sir.
All right. So, on that note, we're going to skip back through some of the fundamentals here. I really I emphasize a lot in this talk that stereotactic techniques are really quite old. And this is more of a general talk in the sense that we're trying to understand the basis for stereotaxis, not specifically the commissioning and other details for the technology. But you know, as early as almost 120 years ago, people were thinking about using external bony landmarks to derive internal targets for interventions. And in the neurosurgical literature, they use landmarks on the external skull, like the auditory canal or the midline. The problem, of course, is that there's oftentimes an unsure relationship between the bony landmarks and the internal structures that you're targeting. And you know, this led to development of atlases or attempts to derive relationships between these external landmarks and internal landmarks. And Lars Lexell was probably the, I would say, father of stereotaxis within radiotherapy, as he was a neurosurgeon that did some experiments on early proton therapy and used this to develop the original gamma knife, which I think most of us are familiar with. And the gamma knife really does exemplify the use of stereotaxis as a targeting mechanism. And since the 1980s, we've been using things like CT to augment and help identify those targets internally, whereas previously we were using, in some cases, really not terribly good imaging. But more recently, as was discussed by Dr. Ganesh, this stereotactic body radiation therapy has been applied, and I'll go through some of the concepts here for how we employ stereotaxis. So this is the original picture of Lars Lexell looking very academic and staring at a skull, using one of these stereotactic neurosurgical frames. And for those of you familiar, this is now, I think, a little bit outdated picture of the new gamma knife frame that is used as a basis for the external stereotaxis. But let's talk about what that actually means. A stereotactic frame really is just a rigid ordering system, and the external rigid relationship that's developed uses a set of coordinates. And that coordinate system is applied almost like a ruler and stuck to the outside of the head by this invasive fixation. And when you have invasive fixation and you have this applied appropriately, you can then use these external coordinate systems to target internal targets. So let's use a couple conceptual differences here. Frame versus frameless means, are you attaching something or not? And invasive usually means, in this case, external coordinate systems used, and invasive is, are you attaching it directly to their head with screws or fixation systems? So here's the example kind of approach. Here is a skull. I apologize for my poor graphics. So let's apply a invasive frame and then fix it with some pins. We now have this thing rigidly attached to this person's skull, And then I can attach to that some rulers. Using those rulers, I can then align an image to this patient. As long as I've taken that image with the frame on, I know exactly where that image is in relationship to the patient. And then if I target something on the image, I can back calculate the coordinate system for where that image target is within that coordinate system. If I then line the patient up to those coordinates, using the coordinates that are still fixed to the patient, I hit the target in the middle because I know the relationship of the image to the coordinate system, and I know the coordinate system is fixed to the patient. So this is the fundamental basis for how we use a stereotactic system to target something internally. Once I've positioned, I've identified, and then positioned the patient at that point, I can then deliver a treatment. And if I've done that properly, that should mean that my target is hit, in theory. So let's talk about a few things. So for most people, the idea of stereotactic radiosurgery, or SRS, has been traditionally a single fraction treatment. And there's been some situations where it's used, but it's most often frame-based. But there are definitely situations where we would like to benefit from fractionation in terms of both normal tissue sparing and, in some cases, advantages in terms of tumor shrinkage or response. And usually this is for larger targets. And obviously, if you're thinking about doing multiple fractions, the patient is going to object if you are doing multiple frames over the course of many days or many weeks, especially if the frame is coming on and off, on and off, and on and off. I think that's something that most patients are going to be quite reluctant to undergo. But it is important to recognize that these two different approaches, the frame-based stereotactic radiosurgery and, in some cases may have differences in terms of their accuracy. And I think that's something we really need to explore and understand, because what we're talking about here is effectively technology and the applications of technology to our targets, which includes the issue of margins and variability. So what happens if I take a frame, attach it to patients, and then measure with a cone beam how accurately these patients are positioned under that targeting system? In most cases, we receive sub-millimeter accuracy. But interestingly, even in a subset of only, in this case, 102 patients, there was one patient who had a 4.3 millimeter slip, where the pin that was attached to the skull slid almost a half a centimeter along the skull. And you can imagine that that would, for a small target at least, lead to a potential geographic miss if you still relied on that alignment, that fixed alignment when you aligned the image to the patient's coordinate system. If that coordinate system has moved, that image is no longer in that same relationship. And so it's important to recognize that even perfect, quote unquote, fixed systems aren't always that way because of this gap in the potential for them to move. So you can also do kind of examinations of the positioning of a phantom versus a patient. And in this case, you can see two different clouds here. You can see kind of a white cloud of dots and a black cloud of dots. And you can see that there's a little shift. And it turns out that when you commission something with a phantom, but you don't do end-to-end testing, there can be differences in how phantoms behave compared to patients. So in this case, when you attach a phantom to the mounting device on the table, it moves very easily, it weighs a few kilos, and that's fine. But if you attach a patient, they have a whole body that drags and pulls on this and creates distortions. And if you hadn't done a patient-specific QA assessment, which is to say a cone beam of that patient there, you wouldn't have recognized that this sort of offset could occur in the difference between the phantom setup and the patients that you're actually treating. And so it's important to recognize that even with the absolute best pre-patient QA processes, you can sometimes have systematic shifts that occur because you're doing something that isn't actually a patient. And so it's important to kind of recognize that. So how do we move from the frame-based concept, that one I showed you, to a frame-less concept? And this is where we're shifting over time to using imaging as our coordinate system. So I talked about the rulers on the outside as our coordinate system previously. What we really think is the most important and most relevant is the actual target itself. So what do we need to do frameless, image-guided radiosurgery? Well, we need to be able to detect errors, we need to be able to correct those errors, and then we need to be able to immobilize or maintain that corrected position through the time of the treatment. And so let's go through the accuracy to detect setup errors. And I already kind of alluded to this when I talked about the cone beam of patients who were in a frame. But the idea here is that if you do registration of images, so cone beam systems on patients who've had a frame, most of the time when you do registrations between a planning data set and a cone beam data set, it's actually quite straightforward to register a skull to a skull. There's quite a bit of image information that allows you to do a 3D match quite precisely. And most of the time, the automatic methods are very, very accurate with less than a half a millimeter of variation in terms of the registration. Of course, by contrast, if you use an orthogonal X-ray tracking system, you get two projections, and then you can look at fusion errors in some cases that are related to the fact that the arch of the skull may not always be easy to tell where you are shifted relative to that. And so even the difference between 3D to 2D can have a relevant difference in terms of the accuracy of setup or determination of the accuracy of setup. What's fun is then you look at the literature and you say, okay, so I'm going to find all the patients that were looked at with 2D registrations and all the patients that looked at with 3D registrations, and I'm going to look at the residual positioning errors that were detected for those systems. And so if you look at these two chunks of data here, you can see in the top that the 2D systems have in some cases 1 to maybe 2 millimeter variation, plus or minus a half a millimeter or so. And the 3D systems indicate that the positioning error is actually slightly bigger, more like 3 millimeters, plus or minus 1 millimeter. So how many people here think that the 2D systems are actually better at setting up patients than the 3D systems? No one? So I just explained that I think that this is probably an imaging issue. And so what you're actually seeing is you can't detect some of the registration errors or setup errors with the 2D system because it's just less precise. It can't deal with rotational errors in the plane of those projections because there are some bits of information that are just lacking. When you have a 3D setup, you can often detect very subtle variations in positioning that you wouldn't otherwise see with a 2D orthogonal pair. And it's important to recognize that if you're using that sort of system, you have some uncertainty or some inaccuracy in detecting those sorts of positioning setup. So let's look at bony landmarks. So if I take a 2D system and look for bony landmarks or a 3D system, can I see the target in either case? Well, not really in a 2D system, unless you've got some sort of weird, hyper dense radiographic element that you're targeting. You really can't see much. But in 3D, you sometimes can. And so what you might want to do is look inside a cone beam to see if you can detect whether or not the target is in fact staying in relation to the external motion that you've already set up. And you can set it up using bone, but you can also in some cases use contrast to look inside a cone beam and determine if you've in fact set this patient up properly. When you do that, you actually see a very strong correlation of the soft tissue registration to the bone match on the 3D analysis, and it makes you pretty confident that a bone match in this case, at least for skull contents, is likely to be just as good or very close to as good as a soft tissue registration because of the rigid relationship of the contents of the skull to the skull itself. And there's really subtle, very small differences between the bone and tumor match on the order of about a millimeter, and some of that might just be the registration error itself. But the nice part is that meant that we didn't see, or this group didn't see, a difference in terms of steroids. So if you had done a planning CT a couple days before where the patient hadn't been on steroids and then you started steroids, the tumor does not shift dramatically and doesn't dramatically change in size, and so you can oftentimes be confident that you're not going to lose that relationship even if your imaging is a little bit older or a little bit dissimilar to what you've done. So how do we correct these sorts of setup errors? So we've detected them with either a 2D system or a 3D system. We talked about this a little bit yesterday, but there's this issue of correction of rotational errors. And inside the skull, there is this problem. So if you have a single small volume ball target and you rotate a little bit, so you can see that I'm rotating this patient just a little bit, not much changes if you have an isocentric setup for this. And that's fortunate because then you can deliver the same plan even if there's a small rotation without worrying about what happens. So for single lesions with small spherical targets and beams not directly related to the adjacent OARs, it's probably not a big deal for a small rotation in this situation. So you don't really have to correct rotations for this situation. However, there are other situations where this does become much more applicable. So you can imagine if you're doing multiple boosts inside a single plan, or if you have multiple targets associated with a single isocenter. And so this is the classic example where you have two targets and you set up an iso for each of them and you try to rotate around this. It's actually quite difficult to set this patient up so both the isos remain on target. And this is accentuated by the distance from the isocenter. So if you have a a long distance from the rotational center, the edges of the targets will be further displaced, and so it can be problematic. And so when you're thinking about these sorts of setups, you really want to be more cognizant of rotational errors and be aware that you could have problems. We've all talked about the 6 degree of freedom corrections. You know, we use these, but realistically, it's actually very difficult to ensure that patients are going to stay on the table. Not because they won't actually stay on the table, but because they react to the idea of the shift in their position. Patients feel even a small degree of rotation, and they will actually tense up and correct the opposite way in some cases. And so you can get very interesting residual shifts as you try to correct. And so I would always do a further repeat scan after you've done this correction to ensure that you haven't had some sort of unexpected patient movement in response to the attempt to correct the previous rotational error. As was mentioned by Dr. Ganesh, it's very important to identify and maintain that you have this relationship of your imaging and your isocentric treatment. If your imaging is misaligned to your actual treatment, you could be very confident that you're lining up the images correctly, but your treatment could be going off somewhere else. And so pretty much every day, we want to ensure that that isocentricity is maintained between the imaging isocenter and your treatment isocenter, and you can use the ball-bearing phantom or some other mechanism, whichever your preference is. But this is something that should be measured, you know, pretty regularly, and you'd like to have an accuracy of less than a millimeter for this as well. So let's say we now have the ability to detect those errors. We think we can correct those errors either with a 6 degree or otherwise. And now how do we keep patients from moving? So intrafraction stability is actually pretty important. And you know, a lot of you are probably wondering why this matters for, you know, frame base where you're fixing rigidly. But even then, you can get people who do a little bit of wiggling. But you can see here that the frame base versus frameless, there is a noticeable measurable difference in terms of the intrafraction stability over the course of a treatment. And so for frame-based, it usually stays below a millimeter, but even, you know, some patients had up to a millimeter or two shift because they wiggled or jostled a little bit. The frameless approaches actually have a slightly higher degree of error, and you can see that up to, in some cases, a millimeter or millimeter and a half. So let's look at the pre-treatment errors and then the post-treatment errors. The nice part here is that no matter how poorly they were set up initially, the imaging step corrects for this and brings that residual error down to a very, very small number. In this case, it's, you know, down close to, you know, less than a millimeter, 0.9 plus or minus 0.6. And that means that the imaging setup process has moved that patient back from a bad registration to a much more accurate registration that you might be comfortable treating. And that's excellent to know because that means that the imaging is working the way we expect it to. And so there's lots of different immobilization strategies. You can use, you know, complicated masks. You can use some sort of mouth bite. You can use combinations of the two. This is a system that we've been using a couple of years back with an extend frame where we had, you know, a very accurate setup, but we still had something like a millimeter of residual error in this setup because of the fact that this isn't a rigid setup. There's still some wiggle in these systems. And the intrafraction stability for almost all of these mask systems can vary, you know, on the order of 0.5 to a millimeter. And this is something that you should know and test within your own institution because it may have implications for what your doses that you're going to be delivering are, because there is some subtle errors that can build up. The problem is that there's a time effect here. So the longer you leave someone on the table, the more they will try to get off the table, even if they're not supposed to, because they're trying to remain comfortable. And so if you look at time courses of treatment and you can measure kind of the residual error in the positioning at different treatment times, you can see that there's almost a linear relationship. The longer you keep the patient on the table, the more likely they are to figure out a way to move to a more comfortable position, which encourages us to keep our treatments as short as possible. And if we cross a certain threshold, for instance, let's say we want to keep our residual error less than a millimeter, if we know our treatment is going to take more than an hour, it may be relevant to rescan and reposition that patient midway through to ensure that we're not going to have the patient drift too far off what we think they might need to be. And there are mechanisms to track that. And so this is in the ICON system, which is one of the Gamma Knife variants, they have a thermoplastic tracking system on the mask, or sorry, a tracking system on the thermoplastic mask, where they put a little reflector basically on the nose, and if the nose moves, they can detect that positional variation relative to the frame. And so you can see here that, you know, the nose acts as an excellent surrogate for the rotation or movement of the head, and if someone's really moving, you can actually stop and gate the treatment. But it really does emphasize the fact that time matters. So when you do this nose tracking on thousands and thousands of treatments, you can see that once you get above an hour or so, you can have up to, on average, a millimeter shift from where you started. And for a small brain metastasis that might measure only 1 or 2 millimeters, this could be a relevant shift that might move you off axis or off target. The nice part about this time problem is that with the active monitoring, it's almost like having a gating system. You can actually turn off the treatment if you get above a certain thing. So in this case, you can see the blue track here is it's okay, it's okay, it's okay. Suddenly it's not okay. The patient coughs or moves or wiggles, and it shuts off the beam long enough for you to comb beam, re-image, and reposition, and then you bring yourself back to a new baseline, and you can resume the treatment. And so this is an example in the same way we would do like a breath hold monitoring or something like that, but this is a nose breath hold monitoring sort of approach. But the fun part is that you can actually predict which patients are likely to have these sorts of events based on just a few minutes of monitoring. And there's AI systems that are now being used to identify patients that are likely to be movers as compared to non-movers, and identify those patients that you should be monitoring more closely. And so maybe for those patients, an hour is too long. Or you may want to be watching for every 15 or 20 minutes, whether or not they're going to jump out of their spot on the table. But the point is that those sorts of shifts can have dosimetric impacts. So if you have a 1 or 2 or 3 millimeter shift, you're probably in the 80 to 90% range. But if you get out to a 5 millimeter or so shift, your dose falls off very, very quickly because these gradients are incredibly steep. In some cases, a shift of 3 millimeters may drop your dose by 50%. And it's important to recognize that if you had that uncorrected or unshifted, your dose could be quite a bit lower than what you've prescribed. And so it's important to remember that what we're doing here with all these correction and positioning things is ensuring the dose is as high as we think it should be. So the dosimetric accuracy with frameless is just as good so long as we maintain those positions. And so in the end, we summarize this. We've got this frame-based and frameless SRS. All of these errors end up being on the same kind of order of magnitude, with the frame-based systems being slightly more accurate, but the frameless systems not being that far behind. And so the frame-based, probably the precision is a little overestimated. As I mentioned, there can be slips, there can be patients moving, there can be lots of things where previously we assumed that they were completely rock solid, and we know that's probably not real. And the frameless systems are actually probably sub-millimeter in accuracy. They're very high precision, and they have a very similar workflow once we think about it slightly differently. So the workflow is just the same now. And so we add a mask, do the patient positioning based on the mask, we do cone beam imaging, and then we define the region of interest for the registration. We use that planning CT to verification CT setup just as we normally would. And then we're going to go ahead and do corrections if necessary, and potentially with 6 degrees if you have that, otherwise you can reposition. And then once you've validated that, you again can move forward with the treatment because you've realigned the patient to that same internal coordinate system. It's the exact same sort of steps that you did with the frame, except you have to do it every day and you use the images instead of the external coordinate system. So that brings us to kind of what happens. So for doses and margins, we used to use 0 millimeter margins and moderate to high dose, minimum of like 13 to 14 gray, with really excellent local control. The delivered doses were probably not as high as we originally prescribed. So if we prescribed 13 and we know that a small percentage of these patients didn't get that, we probably are overestimating kind of our local control rates a little bit, just because we know that some of this is related to missing the target because the frame wasn't as good as we thought it was. But with image guided, we end up with very similar uncertainties, and the question is, I've shown you those uncertainties now, do we need to add margins? And because just like we had that discussion about correction and margins yesterday, if we now know that there are these uncertainties, do we need to change the way we're treating? Should we prescribe lower doses if we use a margin? Because we will be, by definition, treating a little fringe of brain if we add a margin. And so there's a question there as to whether or not that's still as safe as we would expect the frame-based system to be. So somebody did this, and they basically said, we're just going to use the old doses and see what happens. And so I think that's actually not an unreasonable way to approach this problem, because it's a relatively difficult population to obtain long-term overall survival. But in this case, when they used the exact same doses with a frameless approach, they had very similar rates of local control. And so I think this is a very interesting area that's probably ripe for some very detailed exploration of what the actual dose response is when we're using very precise, image-guided, accurate treatments. Maybe we actually need to be giving 8 or 10 instead of 13 because we are going to have a bit more likelihood of hitting the target with an image-guided approach as compared to the frame-based. So overall, though, the results are quite similar when we use similar doses, which suggests that we're in the right ballpark from a dose standpoint. And there's been updated analysis by many, many centers. You're not supposed to read this. This is just a bunch of literature that says the doses seem to work for most patients with similar rates of local control. There are no randomized comparisons that I know of for frame versus frameless. This is a comparison that was done for a center that shifted from a frame-based to a frameless, and they tracked the results before and after. And you can see the local control rates are very similar, though the mask was slightly inferior, but not by much. So the thing about this is patients do care. They really don't like being drilled into, basically, with screws. And so if you ask patients, they have a very significant preference for a non-invasive frame-less approach. They really don't like those screws in their head. And there was no difference in terms of diagnosis or outcomes. The patients just don't like having screws in their brain. So overall, though, we should adopt, ideally, if you can, the non-invasive frameless IGRT approach because it has advantages. The frameless approach has good accuracy and efficient workflow, and there's really lower risks of patient discomfort, and overall, really not a lot of difference in accuracy or outcomes. So we think it's probably worthwhile to do. And I think this shows that when you have a consistent workflow with all the steps that Dr. Ganesh mentioned in the initial setup and also during the process, you really can, increase and maximize the accuracy of your treatment. So I talked mostly about SRS here, but I do want to emphasize that this is completely analogous to the stereotactic body therapy that Dr. Ganesh was talking about. We had these same requirements since the 90s, as he mentioned. But what's interesting is the original implementation of body radiotherapy required a frame. And probably I showed this on the first day here. This is the old stereotactic body frame, which is exactly analogous to the frame that we used to use, or still use, for the skull. And this was thought to be the best way to approach the problem because in many cases we didn't have an imaging approach. And so I treated patients like this back in 2004 and 5 and 6 before the cone beam became a standard on many Linux. And we identified quite quickly that there was an assumption we were making, which is that the target was going to be where the coordinates said they were. And so, I set up the patient, scanned them in the frame, contoured the target, measured the exact ISO on the side of the patient in those rulers where I should line the patient up. And then we used to just wing dose in there, not knowing if we were actually hitting the target. And as you might imagine, we all know that things happen like breathing. In some cases, other complicated things can move that target within the chest. And we now know that it's incredibly important to reposition the patient because of these offsets that can exist. So if I set a patient up to where I think they should be, we found routinely offsets of centimeters in some cases of the actual position of the target compared to where we had planned it. And so this becomes exactly analogous to the situation of the frame, where if we have imaging, we can correct the position down to where it should be. Just as if the frame had slipped on the skull, these tumors can slip within the chest. And so when you look at the pre versus post positioning errors, in our center, we had errors up to a centimeter or 2, in some cases 3 centimeters of offset from the setup position versus what the imaging indicated the tumor should be at. And just like in the brain, if you leave the patient on the table for a long time, they wiggle. And so they really don't like to be immobilized. And so over time, the longer you leave them on the table, the further they will try to get away from where they were set up to. And so after 20 minutes or 30 minutes, we now have, in some cases, up to a centimeter of shift again. And so, again, keeping your treatments short, keeping your treatments comfortable, minimizes that risk, but doesn't make it go away. And so if you have a long treatment, you should consider whether or not you need to re-image the patient midway through to ensure that you're doing the treatment to the right spot. And so, in some cases, some centers chose not to use aggressive immobilization, and were able to show that they were able to do very similar things with just the imaging alone, even if they didn't tie someone down with a lot of vacuums and other complicated immobilization strategies. So overall, the frame-based approach for the chest
is replaceable in the same way I mentioned in the skull by an imaging-based approach. IGRT works just the same, and it's a consistent workflow. So I'll look forward to any questions you have, and I think we've got a minute or two left. Thanks.
Any questions?
Sir, you had said that we can ignore the rotational errors in single isocenter, single lesion.
I didn't say ignore. I said you can, I would say in most cases they are minimal. The issue is that the shape of the lesion has an impact. And so if you have a long or an elongated target with the iso in the middle, you can imagine that if you rotate that elongated target, you quite quickly would lose your, I would say, target validity along the rotational kind of extent, the maximum extent. But for small spherical targets, if your dose distribution is spherical and your target is spherical and your rotational axis is around that isocenter, the dose should end up in the same place. So I wouldn't ignore it. I would just be aware that it's, I would say, not as impactful in most situations.
Okay, because rotational errors is something that we are really bothered about all the times. So
yeah, and I think it's important to recognize it, and especially if you see it happening and you don't know why the rotation is happening, that can be worrisome. And so, you know, we often will set up patients multiple times if we can't get the rotation within kind of an expected range. And I think in some cases we use, depending on the site, anywhere between 1 to 5 degrees of rotation as reasonable. But I think that's the thing, is that you have to recognize the circumstances in which that rotation will affect the treatment, and in other cases you can say this probably isn't going to have a dramatic impact, and therefore we'd be willing to accept a little bit bigger rotational kind of baseline error because we don't think it's going to change anything.
also, sir, as an institutional practice, we have never done that repeating CBCT after taking 6D correction. Is it something that often happens that the shifts change?
Yeah, so it's a fun exercise to do. Is if you, let's say you have a 3 degree of rotation shift for a patient, you can say, you know, hey, Mr. Smith, we're going to do a rotation now. Ask them how they feel before and after, and then take a residual picture. You will often find that the new kind of image you've taken indicates that there's still an offset because they've moved in response to feeling the table move. And so if you're going to do a 6-degree correction, I would definitely recommend taking another image afterwards to ensure that the residual error after that correction is low. Because in some cases it won't be. Not because the table didn't do what it was supposed to, but because the patient didn't do what they were supposed to, which was to maintain perfect stability. Patients are floppy. If you move them in a way that they're not expecting, they can react, and that will create a compensatory motion that will be, in some cases, if not worse, then at least it will create a residual error that's hard to deal with.
Thank you, sir.
No problem. Other questions?
Drew, so for a center, for example, which is starting out a cranial SRS or a body radiotherapy, what kind of checks for a frameless system would you advise? Like, would you ask them to do something special for the first N number of patients?
I mean, I think that's kind of related to this checking of residual errors. So if you know that you're going to be using an imaging-based setup, for the first 5 or 10 or 15 patients, it may be reasonable to take a picture before, a picture after your initial correction, and then a picture after treatment to ensure that the patient ended up and stayed where they should have been. Having that terminal imaging session is oftentimes felt to be irrelevant or not because the dose is already there. But in fact, if you are identifying residual errors that are appearing regularly after a period of time, it may indicate that you have a problem with your mobilization. It may indicate that your treatments are too long relative to the comfort level you're able to provide patients. There's a lot of information to be gained with those images because it really does show you what's happened. And if you don't look, at least for the first part of the implementation process, you may never realize that, you know, for instance, that systematic offset for the shift, you may not see that if you didn't recognize that those images afterwards were just as important.
Have you done something like this for lung SBRT, for example? And
Yeah,
and,
all
would
that
be really
Yeah, all that data I showed you about the patient shifting over time, for the first 100 or 200 or 300 patients, we always took 3 cone beams minimum per patient, and in some cases even more, where we would take an image, let's say we had in 2 arc treatment, we would sometimes take another cone beam between the arcs to make sure that things hadn't shifted in terms of the setup, depending on how long the arcs were. So we took a lot of extra images.
the time dependency that you found. Would that impact, for example, if you were doing a VMAT plan, which is now over in 2 minutes?
Yep.
Would that impact, the margins?
And that's a great question. So the new FFF plans that are delivered in 2, 3, 4 minutes largely escape some of these risks because they are so rapid. But I think, especially if you're just implementing, it doesn't really hurt for the first 10 patients to take 1 extra cone beam, just to be confident that things are working as expected and there isn't something weird going on. We're a big fan of data overkill, as you know, but I think in general, it's a very reassuring thing when you're implementing something to be confident that you've done what you thought you were doing.
Thanks.
Yeah. The mic died again? Oh no.
So my question is that from the previous presentation, we get to know that non-coplanar beams like umbrella-like wheels. So for non-coplanar beams, how do you get the IGRT, the image guidance? How do you take it? Because
How do I check the what? I'm sorry.
yeah, for non-coplanar beams, the cone beam, CBCT, whatever you were saying.
Yeah.
How do you take? Because in non-coplanar you cannot take those. So how to check that?
What we're checking is the position of the patient, not really any of the beam directions or the kind of the plan itself. We're just ensuring that the patient's in the right spot relative to the isocenter. So the type of treatment plan, be it VMAT, be it a 10 beam non-coplanar or whatever, is always based on the setup position to ensure that the isocenter is at the right spot, basically.
Yeah, that's true. But actually, we had experience in Novalis TX with all these 60 couch and everything. So that's the thing you have already mentioned, that when we are giving some kind of rotation, the checking rotation, then there are some residual errors because patient is having a jerk.
Sure.
So for non-coplanar beams also we got the same thing. We had exact track, but as you showed that exact track, that matching is not that, we are not that much confident. So that's the issue we faced. So
Yeah, I don't think the issue is different for a plan that has non-coplanar beams compared to a VMAT plan that has all coplanar or all kind of, let's assume all your arcs are in a coplanar arrangement. I think in both situations, the setup assessment should be the same. Maybe I'm missing something about the type of beams that you're considering. I'm happy to talk about it with you afterwards, but I don't think it should be different for any of those systems as long as you're using and you're confident that the setup is consistent. Indranil, maybe you can, I don't think I've seen a situation where
basically trying to check the setup, and the setup won't change once you rotate the couch. So it's
so
not
the only way to do it is to again take another set of images, another orthogonal
but what
pair.
she's arguing is that you can't take a volumetric image once the couch is rotated. But
Okay, I see what you mean. I missed that completely. That's a great question.
Some MB image to that, because you can do a portal image. If you have a true beam or anything, you can do a triggered image. So whichever angles, if you're going for more than 30 degrees, you can add another MB image and a DRR ready for that. You can just match that, because most of the time when you rotate the couch, it's not going to go up. Anteroposterior shift will not be there. It's always a craniopodial mode and a medial lateral. Little medial lateral, more of craniopodial. It's because of the gantry. So and the couch. So you can see that very clearly when you have an MB image attached to it.
Yeah, I apologize. I forgot about the couch kick, to be honest. We don't use an awful lot of big off-axis couch kicks in our SBRT. We use mostly very small, subtle variations in arcs. So we'll make an arc of 5 or 10 degrees either way. And in most cases, I think we're still able to be relatively confident that patients aren't going to move. And so we don't generally kick the couch by 90 degrees or 70 degrees when we're doing SBRT anymore. It's a lot of mostly VMAT, so.
One last question.
Yeah.
If you have a multiple metastatic lesions and
Yeah.
craniocaudially more than 7 centimeters, normally what we do is that like when you have too many mets and if it is less than 1 centimeter or 7 mm size and they are more than 7 centimeters apart craniocaudially, usually when you do a 60 correction, there is a possibility that if you match this side, the other side you could be an issue. So what normally we do is that if it's more than 7 centimeters, we have a 2 isocenter and do the treatment. What do you do in your clinic?
No, I think that's exactly right. I mean, we're cheating a little bit because we often have, so we're using Gamma Knife and we're using individual ISOs for each of the targets. So it's most of the time that's a cheat for us. But I think you're right. When you have multiple targets that are well dispersed in terms of distance, the rotational areas are amplified. And so you could set a threshold like 6 centimeters or 7 centimeters to say if the targets are that far apart, then you have to go to a multiple isocenter setup to minimize those rotational issues. But then you end up in some cases with uncertainty regarding the dose overlap in certain areas, especially if you have two plans that are very well matched. If you rotate one of them, your doses may not be as predictable or as planned. So it's important to just recognize that when you have multiple isocentric plans that have potential overlap, that you could end up having a little bit of interaction depending on how your setup goes.
Thank you, Dr. Hope. Yeah, we are going to move on to the next talk. That's going to be Dr. Heisman telling us about biophysical models.
Thank you, sir. Our next session is Introduction to Biophysical Models by Dr. Ben. We welcome you, sir.
Thank you very much. Good morning. So, we're going back a little bit more to basics, I would think. Maybe this is called basics. So, introduction to biophysical models. So, I will talk about quantitative models. And so basically, it's about formulas that describe outcome of radiotherapy. And so, I mean, as you will see, probably in your clinic, you will not use all of this every day, and because there's a lot of uncertainties in these models, I believe that with time, or maybe at least I hope with time, they will get better, these models, and be more applied and more applicable. And but we will see. So this is what I will talk about. Not all of this, because I will probably not have time for all of this. First of all, just give some examples of what do I mean with biophysical models. Then I will discuss more in length toxicity prediction and discuss here a concept like equivalent uniform dose and some two types of NTCP models, so normal tissue complication probability models. Then there is a little bit of an intermezzo of a cell survival and the LQ model. Probably many of you know about the LQ model, and then I will discuss a little bit usage of BED and equivalent dose in 2-grade fractions. Probably this is also rather familiar. That is, at least in our clinic, used quite a lot. If I have time, I will talk about some things about models for predicting tumor control and impact of prolonged overall treatment time. So just some examples of biophysical models. So this is old data. You can see this is 2002. This is the tumor control probability versus the mean dose in the prostate. And there is a nice fit through the data, as you can see. And in the upper right, there is a formula describing this fit. And there's two parameters in it, the D50 and the gamma 50. And so this gamma 50 you see it here is the 3, and this D50 that you see here is it's called the TCD50. It's the dose for 50% control, so it's around 70 gray, and you see here the 70 gray. So let's talk a little bit more about this gamma 50. What does it have? What meaning does it have? Well, the meaning that it has is indicated in this formula, very simple formula. So what it says is that if you have a 1% change in the dose, in the delivered dose, so 1% change here, you will have a gamma 50% change in the TCP. So here the gamma 50 in this curve is 3. So a 5% in change will give you a 15% change in TCP. And so this is an example, but this is not a very abnormal example. So it shows us that we have to be really accurate. We're talking a lot about QA here and things like that. They have a meaning, and I mean the meaning you can see it very clearly here for this example. If you are a couple of percent off, your TCP may drop in your patient population. So we have to be very accurate in this field. And this is for TCPs. For NTCPs can even be worse. So the steepness of these curves can even be higher. This is another very different example of a biophysical model. It's very, very simple. It's a linear curve, very, very much used. I think this curve is curved by Sarah Darby. It's about cardiac damage in lung cancer patients, and you see that the probability goes up if the dose goes up. Okay, let's start with the toxicity prediction. I think we're all used to looking at those volume histograms, and so this is some example. You have 2 plants, you have 1 structure. So what is best for this patient, for this structure? And it's not always simple, as you know. So really we need some tools to interpret this. So basically what we need is summaries of 3D dose distributions in a single clinically relevant number. And for healthy tissues, I will discuss 3 of them. So the generalized equivalent uniform dose, and 2 NTCP models, the Kutcher-Berman-Lyman model. That's there are 3 people that worked on that model, and I will discuss machine learning that maybe nowadays is more and more used in the sense there's papers on it. Used, I'm not sure that it's used very much. I'm sure it is not used very much. And then, yeah, for tumors there is TCP. Okay, some basics. Maybe this is not new to you, but anyway, some repeat then. So basically, if you take it very simple, you have, if you have normal tissues, you have them with parallel architecture and serial architecture. And so this is a graph representing an organ with a parallel structure. So these are called functional subunits, and you have to see it like that. So this is the organ. There is a signal coming in the organ, and there has to be signal going out of the organ. And if there is no signal going out of the organ doesn't function anymore. So you should not destroy all of these functional subunits in this one. But in parallel organs, you can basically destroy completely some of these subunits because the flow will still go using other subunits. And so you can simply destroy part of the organ. And so these organs have a large volume effect, means that small parts of the organs may be irradiated with very high doses. Examples are lung and kidney. That are some of the major examples here. And this is an organ with the serial structure. So here you can easily see if you only kill one of the functional subunits, the organ will not function anymore because there will not anymore be a flow. So the examples here are spinal cord and esophagus. So this is kind of what you will show. You will see. Will come back in the next slides. This parallel versus serial. Yeah, if you look at normal tissue complication probability curves, this is for a parallel organ, so this is for lung here. If you if you irradiate the full lung, you get this curve for tissue complication probability. If you treat 2/3 of the lung, you get it here. If you get 1/3 of the lung, you get it here. So there is indeed this big volume effect in these parallel structures. So if you reduce the volume that you treat, you can get in the end you can give much higher doses to that volume. This is a serial an organ with a serial architecture, so esophagus, and you see really it does not matter too much whether you irradiate full organ or just a part of the organ. The NTCP curves are very close. Okay, let's talk a little bit about the GEUD. So the GEUD. So this is the explanation of the concept. GEUD is a concept. It's a homogeneous OER dose with equal damage as the delivered inhomogeneous OER dose. So as you know, normally an OER gets an inhomogeneous dose, and now there is a formula that converts this inhomogeneous dose to a homogeneous dose, the GEUD, and that homogeneous dose gives you the same complication probability. So this is more graphically. So this is the DVH of an OER, and this DVH is converted into this DVH. So really, there's only one dose here, and that is the dose to the full OER. And the two are equivalent. So now the question is, of course, I mean, what is the trick? How to go from one to the other, right? And okay, so that I said it already. So the trick is here, and so this is the first, I would say, real formula. It's still quite simple. So in here, so the dose distribution is in here. You can see. So this is fractions of the OER. So if 10% get a dose of 50 gray, then here you would put in 0.1, and then the dose for that 0.1. Then there is this parameter n. N is the volume parameter of the OER, and that is determined by fitting complication probabilities to this function. And then you can derive this. So this is derived from clinical data. This n. This, if you look at this formula closely, then you will find out that if n is small, so close to 0, the GED will be equal to the Dmax, or very similar to the Dmax of the. And this is, you will see. I will show that later. This is for serial OERs. And if n is around 1, then the GED is if n is equal to 1, then the GED is probably the D mean, it's the same. And this is for parallel organs. Yeah. So this is an example. So I have an OER. 50% gets 40 gray, and another 50% gets 60 gray. So it's an imaginary dose distribution. So if n is 0.05, the GED is 58. N is 0.05, it's close to 0. So, and then we know, and if n is small, then the GUD will be close to Dmax. Well, the Dmax in this dose distribution is 60 gray. So here it becomes 50 gray with this N. So if N is 0.8, so it's close to a parallel organ, then the GUD is 50, and 50 is almost the average of the two here. So that is what you see here. N is close to 1, then you get the mean. Okay, so how can you use that? So this is, you saw this before, this was for a mandible. If you don't know what is best for the mandible, you go to the literature, you can find this number, and it's 0.7, 0.07, and so for plan 1, you get an EUD of 55, for plan 2, you get an EUD of 64.6, so the red plan is basically hotter for the mandible, and so if you want to spare the mandible better, you take the blue plan. Very simple. So let's now go to an NTCP model that has been very popular for many years, this model, and this looks very difficult, so we make it a bit simpler. So there is an NTCP model, and that depends on the GUD, so we just discussed the equivalent uniform dose, and the GUD depends, so the GED depends on on the dose distribution and the N, so this volume parameter, and in this function there is also a TD50, the tolerance dose for 50% of complications, and there is an M. And M determines the steepness of the sigmoid curve. So you have this sigmoid NTCP curve, and the steepness is determined by the M. So these are just two other parameters. So there's really three parameters in this NTCP. There is the N, the volume parameter, to determine the GUD. Then there is the TD50 and the M. And all fit to clinical parameters. Okay, so let's investigate a little bit the role of N using this formula. So this is for a parallel organ. It's really like you saw before. Parallel organ means that there is a big split in NTCPs if you reduce the volume. So, so this is for the full volume. If you go to a third of the volume, you are here. And this is for an N of 0.87. And here's an example for N is 0.15. And then you see that they are all together. And exactly what you expect of a serial organ. Now, impact of TD50 and M. That's very simple. You can see that here. So here are three curves, and here are the different M and M combinations. So if you look at this one here, so 50% complications at 50 gray. So that's exactly the D50 is 50. So, and here the D50 is 60 for these two, the blue and the red. So D50 is 60, and but these are different in M. You see 1.1 and 0.2, and that is why they are different in the steepness. Okay, so we saw this example before. We were at this point. Now we take it a step further. So here you see that plan red, the red plan has a higher dose than the blue plan. So you tend maybe to think, well, probably if I want to spare the animal, better the blue plan. But I mean, this is not an NTCP. So maybe you are somewhere, maybe you are very low in here, doesn't make a lot of difference, or you are somewhere here, then it also doesn't make a lot of a difference in the NTCP. So it's better, theoretically better, if you can trust these models, because I'm very careful, don't go going back home and start immediately applying all this. You have to be very careful. Sometimes you can. But then you see that it makes indeed a difference. So the NTCP of the blue is only 1%, and the NTCP of the second plan is 15%. So there's a big difference in this dose difference. So it makes a difference. Yeah. So the second what I will be looking at is NTCP models generated in machine learning approaches. I will talk a little bit about logistic regression and deep learning. So in contrast to this other model that I just discussed, this Kutscher-Berman-Lyman model, the other models, so this logistic regression and deep learning, you can also include easily non-dosimetric parameters like age, like some dosiomics, radiomics, whatever you can put in there, and so that is some advantage. So machine learning is really is a very in principle very simple approach. So this is called supervised learning. So you learn by examples. So what you need is a database of patients. They have a toxicity, yes or no, and then there is a list of predictors, and you have the value of the predictors. So here as predictors I give examples of GUT, V70, but also other predictors you can use. As a kind of maybe as a short break, I would like to know who of you is using NTCP models in clinical practice. Supriya. Drew is not sure. He doesn't know what he's doing back home. You were also maybe? Yeah. So, yeah, I mean, I think this is the right answer. I mean, you have to be very careful, and so I'm sure that people who use them know how to use them, and so I can tell that I will come back, in my next talk on proton therapy. So in Holland, for proton therapy, we have to select patients, and that is done based on NTCPs, and so that is one application, and I know another application in some, I think it was HCCs, liver SBRT, where we use an NTCP, but on top of other things. So it's only to reduce the risk, and so yeah, okay. Yeah. So first, logistic regression. I think many of you will, certainly you have seen the results of logistic regression in papers. So this is the formula, basically. The NTCP is a function of predictors, and then this is the formula, and this Z is a function of these predictions, and the function is very simple. It is a weighted sum. Very, very simple, really. And this is always also in deep learning, in more complex models, is extremely simple. What is done with the predictors? Simply a weighting, and well, this is how it then looks, such a thing. So this is basically a graphical presentation of this here. So for every complication, you need to find these B values, and they result from supervised learning from a clinical database. And in papers you find odds ratios, that they come from these models, and this is an example. You find here the odds ratios, and you see all the predictors with their odds ratios and p-values. So this is now talking about just an example about deep learning for predicting xerostomia. This was one of the first papers on using deep learning for prediction modeling. 84 patients. This is the scheme. Maybe it doesn't mean a lot to you. But anyway, as an input, you have the CT scan, you have the dose distribution, and you have masks of the relevant OER. So the parotids, the submandibular glands. Oh, it's going myself, and probably the oral cavity. I can see it here. And then, I mean, it goes in here, and then in the end you get a yes or no. And so this looks pretty well. So there are many graphs in here, but we only look at 2 of the graphs. So this is the 3D convolutional neural network. So this is the model that I just showed. And so the curve is, the ROC curve is this one here. And this is a logistic regression. So the other one I already described, and it is this one here. So there is quite a difference. And so the AUC is 0.4, 0.84, 0.7. So I have to say, so there is no, in this paper there was no external validation. External validation means that you have another data set and test the model. And that is really essential, because in these bigger models, so deep learning models, it's very easy that you do overfitting. So it looks really nice in your data set, but if you go to another data set, it doesn't work anymore. So I know that in the Green Journal, for example, they will not accept any more papers if they're on this kind of topics if there's not an external validation, because it's really tricky. You can make, I mean, there's tools to try to avoid this overfitting with your data set, but still they are not perfect tools, and there's enough examples that if you go to another data set, it simply doesn't work anymore. So this is called something like generalizability. This is the term that is used for that. Okay, so yeah, I continue with cell survival and the LQ model. So this is kind of biology more, and then I continue with other things that use this biology. This is very simple biology. So these are cell survival curves for single fraction irradiation. So the LQ model basically is the description of these curves. So the survival fraction is a function, is an exponential function. There is a linear term in those and a quadratic term in those, and that is how you can describe this curvature. So alpha beta reflect radio sensitivity, and alpha divided by beta is very important for fractionation. Yeah, so for individual patients, we don't know these values. That's a bit unfortunate, but there is much more knowledge on, as you know, alpha beta values. And what is also interesting to know and useful sometimes is that for human cells, the survival fraction in 2 gray is around 50%. But there is a huge variation around that, but that is kind of the typical value. It can also be only 10% and can also be 90%, but typically 50%. If you go to fractionated treatment, then you find other formulas. So then the for the fractionated treatment, the surviving fraction, you have to do the surviving fraction of 1, and then do that to the power of the number of fractions. So here is k in the remainder. K is always the number of fractions, and this is the fraction dose. And then so you do it like that, and then with the previous formula of the LQ model, you arrive at other formulas. I will not go through them. Those who are interested can read it later. You will have the slides. I will now go to applications of this, and in BED and equivalent dose in 2 gray fractions. So what we have seen is that for a fractionated treatment, so again, this is the number of fractions, this is the fraction dose, you got this formula. And you can rewrite that in this way, and then you get a definition of the biologically effective dose. So this part here, from here to here, is this here, and that is called the biologically effective dose. So the surviving fraction is the exponential of minus alpha times BED. So BED is also a concept. It's not you cannot put an ionization chamber somewhere in it and then you measure the BED. You cannot. So why do we call it a dose, a biologically effective dose? Well, the unit of BED is gray, so that helps. And what also helps, if the BED goes up, the surviving fraction goes down. That is what you want from dose also. And so if this gets higher, so this gets bigger, and there is the minus here, so it goes down. Yeah, also what helps is for different fractionation schemes, so this is then the fraction dose, this is the total dose. If they have equal BED, they are equally effective. And so if the BED is the same, it only depends on BED. So it doesn't depend on really how much this is and how much this is. If there is a certain fixed BED, you always get the same effect. And that, so the same dose, the same effect. So it's really kind of a natural thing to call the BED indeed a dose. And so for tumors, you know this. So for late effects, alphabet is 3. And this is something also true. So you can add BEDs if you have treatments in consecutive fractionated treatments. You can simply add the BEDs. So another concept is equivalent dose in 2 Gray fractions. Also can also be very useful. So the equivalent dose in 2 Gray fractions is given by this formula. You can very easily derive that. You can very easily derive that from this here, equivalent dose in 2 Gray fractions. So how is that defined? So this is, suppose you have a fractionated treatment with a total dose D and a fraction dose of D, and then you calculate this equivalent equivalent dose in 2 Gray fractions, and then it means that the D, so the original fractionation scheme has the same biological effect as one given in 2 Gray fractions, and now this is the total dose. Yeah. So this is the equivalent dose in 2 Gray fractions. Very useful sometimes. Some applications. So this happens with some frequency in our institution. So you are dealing with an unplanned treatment interruption without, and you do not want to change the overall treatment time or cannot. So this is an example here. This is a patient with colorectal cancer. The plan is 5 times 5, preoperative, Monday to Friday. Next Monday, there is surgery. And the patient is sick on Wednesday, so no treatment. And it is decided to increase the fraction dose on Thursday and Friday to compensate. And so then the question is, what fraction dose to give on Thursday and Friday to have the same anti-tumor effect? Well, we do that with BED, so this is the formula of the BED. And so the plan for Wednesday and Friday was 3 fractions of 5 Gray, total dose. So this is total dose here. And so this is the alpha beta, the fraction dose again, is 22.5 Gray. So this is planned. So this is also what you want to deliver if you only treat on Thursday and Friday, not on Wednesday. And so for treatment only on Thursday and Friday, we have an unknown fraction dose. And the BED for Thursday and Friday is now 2 times 2 fractions of this fraction dose, and then the fraction dose is also here, always referring to this formula here. And so this has to be 22.5, and then if you do the math, you find that the fraction dose is 6.7. So to make up for one missing fraction on Wednesday, on Thursday and Friday, you have to give a higher fraction dose to have the same anti-tumor effect, and that increased fraction dose is 6.7. So instead of 5 that we would have given normally on Thursday and Friday, we're going to give 6.7. Second application, yeah, this is a bit more complex maybe. This is patient-independent risk-adapted fractionation in stereotactic body radiotherapy. And the liver is, the example is on liver SBRT, so we're doing quite some liver SBRT. Our clinician involved there is Dr. Alejandra Mendes Romero. So this is a protocol that is used in all of Holland and in Belgium. And there are 4 fractionation schemes that can be used. So 3 times 20, 5 times 12, 8 times 6, 7.5, 12.5, 12 times 5. And I mean, preferably this is given, I will show later, because it has the highest BED. But if this cannot be given for OER constraints, we go lower and lower and lower. And so analyze this a little bit. So we have this BED formula, and then for 3 times 20 gray, you find that the BED of this treatment is 180 gray, and if you go to more fractions, it's always 60 gray as you can see, but as you go to more fractions, you get a lower BED. We know that, it's known that, at least Alejandra tells me, so I'm because I know that Supriya is here, she will correct me. So Alejandra tells me that you need to give more than 100 gray. So we try to avoid the 12 times 5 gray, and but sometimes cannot be. And yeah, so this is so we're not going to look at all these numbers here, but this is you saw data for the tumor. Now this is for the OAR. So here are all OARs in here. These are again these fractionation schemes, and so for example for liver minus GTV. So in this scheme, the 700 milliliters has to have a dose smaller than 15 gray. Here, 700 milliliter, a dose smaller than 18 gray, smaller than 21 gray, smaller than 24 gray. And so basically what happens is that with all this here, we always keep the same EQD2 gray of 36 gray. You can see that here, EQD2 gray. So we do not, I mean, if we go to let's say if you take a very, if you go from a few fractions to more fractions, so then we can, what you can see that the dose increases, but in a way that we always keep the same equivalent dose in 2 gray fractions. So all these schemes are equivalent for the OAR. Third application, and BAD again. Yeah, this is a very useful one if you analyze data. So simultaneously analyze treatment outcomes for treatments with several fractionation schemes. This is an example from the literature, but that's done quite a bit. And so if you have different fractionation schemes, yeah, how to combine these data. And so here they have this. So here is BED and tumor control probability, and what they did is, so they made this fit through the data, and this fit is for alpha beta. They found alpha beta is 8.6 gray, and then you can see it really nicely goes through all the data points of all these different fractionation schemes. So there's schemes of one fraction, 3 to 8 fractions, more than 10 fractions. Fourth application of equivalent to dose in 2 gray fractions. This is what I also myself find sometimes useful, and more, of course. I mean, when I started some years ago, everything almost was 2 gray per fraction. Now, of course, there's many other fractionation schemes, and sometimes I see a scheme and I think, whoa. I have no feel for what that is. Is that a high dose or a low dose? And then I normally calculate the EQD2 to figure out, I mean, what it would be in 2 gray fractions. So for example, maybe if you're not familiar with 8 times 7.5 gray, you could think, well, I mean, how many fractions should I give in 2 gray to have the same effect? So, and you can do that with equity 2 gray formula like that. So for the tumor, so this 8 times 7.5 gray, if you use the formulas and use these alpha beta values, so the tumor is 3. So for the tumor, you would find that the dose is 88 gray, so it's 44 times 2 gray. So 8.7.5 is the same as 42 times 2 gray for the tumor. So in my field, well, high dose, rather high dose. And for the OER, with an alpha beta 3, the equity 2 gray is this year. And then you end up with 63 fractions of 2 gray. So for an OER, that is really high. So, I mean, you can only do that with of course, with SBRT. You cannot, I mean, really, you cannot touch an OER normally with this type of dose. And then, yeah, 1 minute. The last application is simultaneous integrated boost, and you want to convert it into an equivalent sequential boost scheme. This is an example. So primary tumor 70 gray, elective nodes 54.25, everything given in 35 fractions. Alpha beta tumor is 10 gray. So if you can see that for the elective nodes, the fraction dose is 54.25 divided by 35 is 1.55 gray. So what is the equivalent dose for the nodal area? This is the formula. You fill it in and you find it's 52 gray. So that's approximately 26 gray of 2 fractions, of 2 gray fractions. 26 fractions of 2 gray. And then you know that 35 times 1.55 gray, so that is the simultaneous integrous scheme, is equivalent to 26 times 2 gray. And the sequential boost scheme is then equivalent to this sequential boost scheme is equivalent to this SIP scheme here. So 26 gray 26 fractions of 2 gray, you have to give it to the primary and elective nodes, and a 9 fraction of 2 gray, you have to give it to the primary. Yeah, so so unfortunately, but not too dramatic, I cannot go to the tumor control, because I think who's using tumor control TCP formulas in the clinical practice? Who? But he's doing like that. It's not clear what it means. And yeah, so that almost nobody, because these are not reliable, Drew. Okay, thank you very much.
Ben, quick question. Almost all of the models there rely on a relatively confident understanding of what alpha beta is for a given tumor.
Yeah.
How accurate do you think the alpha betas are in the literature for different diseases based on histology, and especially in the context of multiple systemic therapies? How do you feel like that changes alpha betas, or how do you deal with those sorts of issues when you're talking about these models?
Yeah, also for, you're referring more to this part of the BAD and things like that, right? So if you look in the literature, there was a long time that we believed that that prostate was 10, right? And now we are, I don't know what the latest value is, 1.5 still, or no?
Yeah,
we don't know.
There's a,
sorry?
It's 1.5.
Yeah? Yeah, but also there is also bandwidth there, right? We don't really know. Maybe it's patient dependent, maybe it's systemic therapy. So, all with caution, all these things. So, so better to avoid treatment interruptions. If the patient is sick, you can't do anything. But if the machine breaks down, better go to another machine, and something like that. So you use these. There's another part that I didn't talk about of overall treatment time. You can correct for that also, but maybe then treat in the weekends, or give 2 fractions a day with enough It may be better than trying to correct with some formula that is very shaky.
And Ben, you know, about the N and M in the NTCP models.
Yeah.
I guess they're not just organ specific, but complication specific as well, isn't it? In terms of, you know, for, say for example, the bladder, I'm pretty sure that the N will be different from, you know, a urinary stricture in a prostate cancer patient and hematuria because of, you know, telangiectasia. They're two different complications on the same.
Yeah, I didn't mention it, good point. Yeah, so these N, M, and also TD50, they are symptom dependent. Yeah, so it's not that the bladder has something, no, it's symptom dependent. So,
Ben, can I ask you one question? How is DVH, area under the curve, different than EUDG? Will they yield different results?
Can you maybe, sorry.
How is calculating? So for example, if I have 2 dose volume histograms,
Yeah.
right? How is the estimation of if I do a full area under curve
Yeah.
versus an EUD, just putting the A or G value? Do you expect different outcomes?
Oh.
Because my understanding is that G value is very arbitrary in literature.
So you are asking about a comparison between this GUED and the area under the curve?
Yes.
Yeah, actually, well, I don't know any, I'm thinking now, I don't know any, let's say, kind of background for using the area under the curve. I don't know whether, is there a background?
You know, in the area under the curve will not take into account the difference of effect of a higher dose versus a lower dose.
Yeah.
Because the N value is really the key difference between them.
Yeah.
So, but I'm not aware of any clinical or literature comparing these two. Yeah.
Because we were struggling a bit testing this, so I wanted your opinion.
Yeah. So exactly what there's no weighting of those in there, and so low and high dose. I mean, you can have differences. You can have the same area under the curve, but very different. I mean, in one you can have more high dose than in the other, and so I'm not sure that's. I'm not aware that there is data for this, but maybe there is.
I mean, I think you can fit it empirically, right? So if you have the alpha of 1, I believe, that's mean, right? So mean in many ways is approximating the area under the curve if you assume all the dose bins are equivalent.
Yeah.
So if you move away from an alpha of 1, you're effectively fitting the data to weight either the low end or the high end bin-wise proportionally higher. So basically that's the simplest way that you can think about it, is that if the mean dose, which is kind of the summary of an equally weighted DVH, is alpha of 1, and that doesn't fit the data best, then you go exploring to find the part of that alpha that is more representative or fits the data better. So that's the way that we've always looked at it, is that it's effectively, you start with mean and then you move away from it if the data suggests that it's not representative.
Okay, thank you.
Yeah, I think it's a nice way of explaining it. Yeah, so there is the weighting in it, and you don't weight if you.
So I think the area under the curve would be assuming that the organ is entirely parallel.
Yeah.
So, but if that's not the case, or for that particular complication, if that is unlikely to be the case, for example, for a stricture, that's not going to work. But it may work for, lung toxicity, for example, which is entirely mostly volume dependent.
So, Dr. Ben, that is very nice presentation. Again, my question is that in SBRT, there are multiples of tools regarding the site specific, that is lung or the prostate. But how much extent LQ model can be extrapolated to these SBRT things?
Yeah, that's an excellent question. So I mean, there is mechanisms that in some way that lead to I mean, if you have these survival curves, that they would be a little bit more like that, and there is mechanisms that they would be a little bit more like that, and I think there is not an accepted model for SBRT that I know of, because it's a very complex thing. So if you go more down, then I mean, Dr. Ganesh talked about vascular damage. I mean, yes. Then you go down, and so it is. In my knowledge, there is not a model specific. I mean, that kind of validated model specific for SBRT. So what we do, we use the, let's say, the classical modeling of for SBRT. And but if you're higher than 10 gray or something, maybe you have to be more careful. It's less certain what the impact is.
So there can be tumor control probability may dominate over the normal tissue complication probability. So we have to get more tumor damage or tumor killing property so that we can achieve higher doses through the SBRT. But again, there is a direct damage or the vascular damage may predominate, and theoretically we cannot reach to that type of tumor cell killing. Cannot be explained on the basis of LQ model.
So I think the message here is be careful, and in applying these models. I mean, sometimes you have to do something, but there's a lot of uncertainty, and so as you have seen, we have. I mean, so this liver SBRT for liver metastases is a clinical protocol. We use these values; they are calculated with these numbers, and then normally what you say, and the patients do well.
That is fine.
Yeah.
Let's shorten.
Thank you, Dr. Payne, for this informative session on biophysical models. Now, we request all of you to kindly assemble in front of the admin building, which is right to this hall, on the right side of this hall, for a group photography. Then, we'll be dispersing for a short tea break of only 15 minutes. Thank you.
Back, our next session is particle therapy, physics, technology, and radiobiology by Dr. Ben. Over to you, sir.
This is the wrong presentation. Anyway, I can just, I think it's maybe that one. So, at the risk of you getting bored of me, I will try to give this second presentation. Unfortunately, there was the break in between. So this is about particle therapy, technology, physics, and radiobiology. After this, there will be a presentation by Dr. Gupta on more clinical aspects of particle therapy. Some disclosures. So this will be up. So the title that was given was particle therapy, without any discussion, but hopefully with agreement. I changed that to proton therapy, because in 2 days I will talk about particles, heavy particles, so iron basically, and so I will talk about proton therapy. So these are the topics: the beamline, physics of intensity modulated proton therapy, some biology of proton therapy, patient selection, and conclusions. So this is about the beamline. Often systems look like that. So you have a particle accelerator, so a proton accelerator in some way. This is a cyclotron, there are other types. Then there is a very narrow beam coming out, and that is going to be transported via magnets to the gantry, and then the beam goes like that and like that. And here you can see the patient, so you can see these are immense systems, very big. And I mean, so the patient almost seems, you hardly see the patient, but fortunately, I mean, this is all close, so the patient does not see all this. There's a few things turning around the patient, but the patient doesn't see it. And so for the patient, it's a normal treatment room, but it's big from the outside. So this is, so I connected to a proton center, the Holland PTC center. So we have something, we have two gantries, and then this is a research bunker, and then there is an eye line. So here you see that, so the proton beam is moved to this gantry here, and this is an example where the beam is moved or transported to the eye line. Basically, there are two ways for delivering of proton therapy. There is passive scattering and pencil beam scanning, IMPT, intensity modulated proton therapy. So this is, I will mainly talk about this one, or no, I will only talk about this one. This is the more modern way of delivering proton therapy. This is not done in the more modern systems. This is normally not implemented, so you get intensity modulated proton therapy, and I will discuss later a little bit what it is. So physics of intensity modulated proton therapy. Well, yeah, so very typical, probably you have seen all this. So the proton pencil beam is a very narrow beam, right? Results in a dose distribution with a Bragg peak. Here you see it in a kind of with a film. And this is the dose distribution that comes with it, and this is another way of presenting the dose distribution. So there is a peak, the Bragg peak at the end. And well, I mean, these machines, they can produce protons with various energies, and if you see here the energy goes up, then the deeper the pencil beam goes into the tissue. So this, so IMPT is done with pencil beam scanning. So there is this beam of protons. So they have a charge, and you can move them with magnets, and that is what's done. So very schematically here. So this is the target, and now you're going to the deepest layer of the tumor, and you're going to cover that with pencil beams. Then you have to go, we're going to fill now this layer here, and to do that, we put a range shifter in here. Range shifter is simply an absorber. So they get, it means that some of the energy is already absorbed in the range shifter, so it means that here, the beam stops before the end, really. And then, again, a range shifter, and the last part of the tumor is irradiated. This is basically the principle of pencil beam scanning. Yeah, this is the principle of selling proton therapy, and this is normally how you sell it. Sell it in the sense that you try to convince others that's a really good idea. So this is radiation dose, this is depth in tissue. So this is an X-ray beam, the PDD. So this is a so-called spread out Bragg peak. So you spread out Bragg peak, you see one here also, is produced with lots of Bragg peaks, single Bragg peaks with different energies. So all this together here, produces this spread out Bragg peak, and you see it also here. So, I mean, this is, I think, if you only look at this, you're very convincing. So you don't have those here, all this dose here, and there's no dose here. So this seems really good for the patients. And then this ends up with very beautiful dose distributions. So these are comparisons with VMAT and protons. So you see big differences. All this low dose, you don't have it. And also for this patient here, it gets much better. Here, all these patients. Okay, another story is that, I mean, protons also have disadvantages. And for example, if you go deep in the patients, the penumbra can get worse than for photon beams. So here you see 25 centimeter depth, and this is 15 MV and protons, you see 15 MV is better. 18 MV is almost the same, but if you go to 6 MV, we'll be here. So protons at larger depth have a bigger range, have a bigger penumbra, and penumbras, you don't like them in radiotherapy. Also, when in head and neck cancer, you have to use a standard range shifter, otherwise you cannot treat the superficial areas. And also a range shifter is a piece of metal. You get a broader dose distribution, a broader penumbra. So that is not really advantageous, but necessary for head and neck. Yeah, IMPT is also highly sensitive to setup errors and anatomy changes. And this is some data from some study in 2017. So what they did is they had an IMPT plan based on a PTV, you see, as planned. And then they did a recalculation based on the repeat CT scan at day 20. And if you then look at the CTV and PTV dose, so this is the plan, and this is the recalculation. And you see there is underdosage now in the recalculated plan. If you do the same for the photon plan, it looks like that. So there is no deterioration of the plan. Photons are relatively, normally, depends on the situation a bit, relatively insensitive to anatomy changes, or at least translations for sure. And so they are less sensitive. Protons, as you can see, are really sensitive if you change the anatomy. I don't know what actually changed between the planning CT scan and the fraction CT scan, but apparently there was a change, and it resulted in an underdose for the target. Another problem or limitation or challenge, whatever you want to call it, are range uncertainties. So there is uncertainty in the calculation where this Bragg peak will stop. And you don't know exactly where it stopped. It calculates somewhere in the CT scan of the patient where it will stop, but there is uncertainty. You don't know exactly. And uncertainty, normally we account with kind of a 3% uncertainty. It means at 15 centimeter depth, there's an uncertainty of 4.5 millimeters. And you don't know where it actually stops. This is an explanation of dose degradation due to shift and range error. So first a patient shift. So let's first this here. This is the planned situation. So pencil beams are coming in from this side. This is the patient. There's some bone in here, and then there's the target here, right? And now the patient shifts. The patient shifts in this direction. So the bone is now here. The bone was in the middle here. The bone is now under the center, right? And also the target shifted a little bit. If you now look at the dose distribution, you see where this one here, now there is bone, there was no bone, so you expect the dose here, but now the dose is here. And this one here, there was bone in the planning, no bone here, now the dose is here. Here there's no dose at all anymore. I think you understand that all this here, you cannot compensate that with a PTV margin. You have to have different techniques, and we'll talk about that. So a PTV margin does something on the edges, but this gives problem in the middle of the target. Yeah? So in IMPT setup, problems cannot be solved with PTV margin. So this is another example, very simple. And the upper part is what was planned. In the lower part, you see what happens with range uncertainty. So in real practice, the beams, the pencil beam didn't penetrate as much as you planned, and then you get the dose in a different position. Yeah. So, and that also, there's no way that you can do something with the margin. It's not due to a margin. It's not on the edges. It's in the middle, right? Yeah, this is an example of a patient, how it can look like. So this is left is a CT scan before treatment, right is a CT scan halfway treatment. So this is a very nice dose distribution, as you can see, and it completely got, well, almost destroyed, you could say. You can see that you can go even to very low doses. Also here, this is low in the target. And well, this is problematic. You have to do something with that, hopefully. So there are challenges in IMPT. So there's in the dose distribution, so they are sensitive for patient setup errors. There is this proton range uncertainty, and there is also uncertainty because of variation in changes of patient anatomy. And these problems are really bigger than for photons. So there are solutions. Proper selection of beam angles, I will not discuss that now. Robust planning, I will discuss that. Dual energy CT, if you use for the planning a dual energy CT, then you can reduce the range uncertainty. The range uncertainty, yeah. So you can predict more accurate where they will actually stop, these pencil beams. And then there is, of course, adaptive radiotherapy, which I will not discuss in more detail. So currently, if you look around, this is only offline, and online is not commercially available. There's a lot of research. We're also doing a lot of research on that, but it's not feasible yet clinically in commercial systems. In Switzerland, I know they have their own system, and they just treated 5 patients or something with online adaptive. Okay, what is the scenario-based planning? So what is robust planning? So instead of using a PTV margin, so what you can do in proton therapy is using robust planning. And the essence of robust planning is that you don't make a plan for one CT scan. So for head and neck cancer, we make a plan of 19 CT scans per patient. And they are not really independent CT scans. You have one planning CT scan, and then you have a CT scan that goes a bit up, a CT scan that is a bit lower, a bit to that side, other sides. And also, you can see that here, right? So so the CT scan was moved a little bit in this direction. So this is the nominal scenario. So the normal CT scan, and then you move it a little bit to this side. You move here. You simulate problems with the range uncertainty, so not far enough, too far, and this is exactly good in a nominal scenario. Here there's also a setup error. So you have 19 for head and neck cancer of these scenarios that we use, and you make one plan that is good for all these scenarios. That is what you do. And that works. So this is an example. So this is the nominal. So this is an example for one of head and neck patients. And so this is the nominal scenario. You see it's a very strong, nice dose distribution. But it also, if you do in the other scenarios, so with the shifts, and it remains okay. As you can see, also range errors don't affect. Because in the optimization, you make sure that also the other scenarios are covered, that they are good. So it's a bigger optimization problem. So the price to pay for a robust plan is not free. You can see that here. So this is set up robustness of 1 millimeter. So this 1 millimeter, and here you see 7 millimeter. That is how big displacements you have of these CT scans in the robust planning. So if you have only 1 millimeter, you can see that the dose is very conformal. But if you go to 7 millimeter, you see that the dose is getting less conformal if you compare here and there. And that is, of course, logical, because, I mean, you also have to cover situations
that have really a bigger displacement, and so the dose has to become bigger. And that has impact. And so this is some simulation work. This is NTCP for xerostomia, and if you include higher setup, bigger setup errors, basically this in this direction is higher setup errors, your probability of xerostomia will grow up quite dramatically, I would think. So there is a price to pay. But this is just to showcase our center. So what we have in-room in-room CT scanner on rails. Here there's a robotic couch, and so this in theory can help us with art, but so we are only in the research phase of that. So some biology of protons. So protons are biologically more effective than photons. So for the same dose, the protons kill more cells. And that is expressed by a number, the relative biological effect. That is the photon dose divided by the proton dose for the same effect, biological effect. And normally, you take an RBE of 1.1. Everybody in the world, I would think, takes a 1.1 for that. And that means that you think that protons, now that you have to give 10% less proton dose than for photons. So if you have a normal treatment for photons, 70 gray, you would give 10% less if you want to copy kind of this for protons, right? And so in protons papers, they often report the physical dose, proton dose, times this RBE value, and what you then get is doses. I mean, so what they report is the photon dose with the same effect. That is what they report. Okay, so the current practice RBE is 1.1 always, and that is determined from, actually, that was determined from this graph here. So lots of experiments, in vivo experiments, and you see there is a big spread. So here's RBE and those values, and so a lot of spread. Basically, most of them are higher than this 1.1. And they decided to choose for 1.1 to anyway ensure, so the intention was to ensure that, I mean, that underdoses with the protons would be minimum. Yeah, so if you take it low, the lower you take it, the less risk is there for underdosage. So if you take it higher, then you assume that these protons are really much more effective, but if they are not, you underdose the tumor. So you take this RBE value a bit lower to avoid that. So RBE is a very complex thing, so it depends, and not very well known, so it depends on the dose per fraction, on the LET, the linear energy transfer. The linear energy transfer, I will come back to that later. What that is, so these protons, if they pass through tissue, they have a certain track, right? And the LET is a measure on the ionization density along the track. So if the ionization density is high, then the LET is high, and if the LET is high, then you have higher biological damage, right? So higher ionization density means higher damage, more damage. But it's also depending on the type of tissue, the endpoint, interpatient variations, sensitivity, lots of things unknown, basically. And this also, I mean, this really complicates the learning from more than 100-year photon-based radiotherapy. You will see on Sunday for carbon ions, this is even much more a problem. But also for protons, this is not a simple thing at all. So here, what you see here, this is depth, and this is the LET, and here is the dose. So there are two curves here. So the green is the PDD of the bragg peak. So you see that. So this is the PDD. This is the green. And this is here is the LET. So it's quite stable. And then in the bragg peak, it really goes up. And suddenly at the end of the bragg peak. So because the LET at the end of the bragg peak is higher, the RBE there will be higher than somewhere here. Yeah? And that has consequences. And so there is claims of observed excessive toxicity in the brain. And I use the word claims because, some studies see it, other studies don't see it, and so it's not so sure. What I can tell you is that in our center, for some brain tumors, we have, in all of my country, in the Netherlands, we have stopped treating them and first analyzing all the data of the patient that we treated to see how safe this is. So it's not a theoretical problem, maybe. At least there is concern. Maybe we are more focused on it and now see it, and we didn't see it for photons. Don't know, but yeah, there is a concern. So what are solutions? And maybe a solution is include lead or RBE in planning. Well, this is very badly known. Lead is a physics property that you can calculate that, so that is more realistic in a simple way. And all this here is already done for carbon ions, as you will see in 2 days' time. So some other biology. IMPT to reduce immune suppression and enhance effect of immunotherapy. So we're talking about immunology, really. So what you can see is that, there's much less dose in all these areas here, and that could be a trick that for immunology, IMPT is better than photons. So killing of live lymphocyte, you know that can lead to radiation-induced lymphopenia. There's increasing evidence that this radiation-induced lymphopenia is associated with deteriorations in outcome. The lymphocytes, they're very radiosensitive. So already at 2 gray, you kill 50% of them. And, but in IMPT, you have these smaller dose baths, so compare this here in IMPT with this here. So maybe, there's more lymphocytes remain, or probably they remain. And they remain. And so there is really quite some research ongoing now to maximally avoid this radiation-induced lymphopenia with IMPT, but without compromising coverage and other OERs. So it's not so easy always to do it. There is also some evidence that the benefit of immunotherapy may be greater when combined with IMPT instead of IMRT, and this is discussed in a paper by Durante in 2024. So the radiotherapy turns down the immune response to checkpoint inhibitors. That is what really this paper is about. And so, I hope this is true, really, because this could really be could give, let's say, a new incentive to using protons, and maybe with a big impact, and potentially. And there is, let's say, some evidence for that, and I will discuss that. So I will discuss this paper, and so this paper is a recent paper in 2024, and it's from Taiwan. It is a multi-center study, and they had a database of 60,000 patients. They did propensity score matching, and then 982 patients were left over. So, and with a ratio of 3:1 IMRT protons, right? And so this was for radical curative radiotherapy, no surgery. And this is what they found. So much better overall survival, much better cancer-specific survival, better local regional control, and also, no, the distant metastases were the same, that the p-value is not good. And yeah, is this true? And nobody knows. It's not true, I think. I can tell you, I was recently in a paper of, I would say maybe in Holland, the guy that does more on protons and head and neck cancer is Hans Langendijk, maybe some of you know, and he has seen the same. He has not published it yet, and as far as I know. And so, but this would be fantastic. So this was not expected. The doses were the same. So this is really a retrospective analysis. I see really people laughing, and they don't take me seriously, but I take the paper seriously. And so no, I mean, I think this, yeah, if this is true, I mean, maybe not to this extent, but to some extent, then you get, I mean, proton therapy will be really in business. Patient selection. Oh, I have a couple of slides. So patient selections in my country. So we have two indications, standard indications and model-based indications. Standard indications, every patient with a certain type of disease can be treated or will be treated with proton therapy. There are, I mean, so pediatrics, ocular, melanoma, you can read the others. So this is standard. But the majority of the patients, I mean, it's not that you as a doctor can send the patient to a proton center, please treat it, or the doctor or the patient goes there with a lot of money, please treat me with the, that doesn't work like that. So, so this is model-based. So in model-based, what we have to do is, for each patient, we have to make a proton and a competing photon plan. And the selection of the protons is a substantial NTCP gain. And unfortunately, so in 2021, so we had 281 standard indications and 740 model-based indications. So this is a bit the ratio. Yeah, this unfortunately I don't have it in English, but I will explain it a little bit. So this is an NTCP formula for grade 2 xerostomia. What you can see in here is the square root of the mean dose of the parotis ipsilateral, the square root of the mean dose of the parotis contralateral, and then the mean dose of both submandibular glands. And well, this is kind of the same formula, not the same formula, but so this is, by the way, as you can see here, this is logistic regression. You remember maybe this morning that I talked about logistic regression. This is logistic regression. So also this here is in Dutch, but it doesn't really matter. But you can see here, you see 10% here, you see 15%, 5%. And so you need substantial gain. And so for grade 3, the gain has to be smaller than for grade 2. For grade 2, you need 10, 15% depending on the situation. Gain with protons compared to photons to be able to treat the patient with protons. So these are my conclusions. MT is expensive, cost, building, equipment, long treatment times. It's also complex, as I've tried to explain. There are lots of opportunities, also for technical work, adaptive radiotherapy, maybe exploit RBE differences, there are ideas about that, enhance immunotherapy, hopefully. Yeah, so there's not yet a high level of clinical evidence in my knowledge, so very few randomized trials are high-level data, but there's many trials ongoing. But Dr. Gupta will know much more about this, and many trials ongoing. So I believe that, but maybe he will tell you better, that in some years we will have really an idea of better idea on what patients to select for proton therapy and what patients maybe can be even better or equally good treated with photons. Thank you very much.
I was going to ask if somebody has a question.
Sir, you told that you compare proton and photon plan
Yeah.
at your center. So whether you compare robust proton plan with photon, or how much means the robustness and all, because what we observed in head and neck case, in a nasopharynx where the optic structures are nearby, so if we consider the robust optimized plan, then it will be the target coverage will be, we have to compromise the target coverage. So what is your overview on that?
So, so the basic idea is that, I mean, the target coverage in both plans will be okay, and indeed this is robustly planned, and so serious plans, and with the photons is a PTV margin, as normal as we normally use for photons, and there is examples. So normally you got, in our experience, normally we get the target coverage, okay, so we can focus on normal tissues. But I mean, certainly for nasopharynx that doesn't always work, and then it becomes more complex. And but I don't think that for protons we got better coverage than with photons, and in the cases that okay.
So I think, Prakash, the comparison will happen only if you have an acceptable coverage in proton versus photon. If you don't get an acceptable coverage and you are underdosing because of the robust optimization for preserving the optic pathway, I don't think that the model would be applied. I mean, you would treat those patients on photon rather than on proton.
Because when we are going for the robustness, like if the prescription is 70 gray and the optic structure I have, okay, in nominal scenario it is 58 gray,
yeah.
But if I want robust, if I want PTV coverage or CTV coverage, it will exceed up to 62, 64, which is not acceptable in robust scenario.
Yes, I think that is what both of them are trying to say, is that first you have to ensure that you have target coverage. Only then can you compare the proton versus photon.
Yeah, it's really based on normal tissues.
Yes.
So, yeah. Otherwise the comparison doesn't work. I mean, you have to have coverage.
Yes, I think Supriya.
Is there a different philosophy when you're using definitive versus adjuvant radiation? Because the gain of proton goes away the moment you indulge in robustness evaluation.
Yeah.
So what do you do in breast cancer versus head and neck cancer? Do both undergo robustness evaluation?
Yeah.
Or adjuvant is nominal?
Yeah. Yeah, so yeah, we also treat breast cancer, and this is robustly optimized, and it's a good point what Supriya is bringing up. So, so there's also robustness evaluation, and that is on more scenarios we use. So we make a plan for 21 scenarios, but we evaluate on more scenarios. So, but that is done also for breast cancer. Okay. Yeah. If maybe some remark in between. So there is also, not everybody in the world uses robust optimization. There are different techniques around, also with PTV margins, but I would think all institutions do a robust analysis. So if you have a plan, you can simply move the CT scan around in the dose distribution and see whether it's robust, right?
If we treat patient with protons, if daily variation in interfaction setup errors, daily means day by day there is variation in setup. So how much is the margin for setup errors due to skin changes or bone anatomy changes?
I don't hear it well. Can you?
He's asking about setup margins in proton therapy.
Yeah, so there is no setup margin, but there is this what is called the setup robustness parameter, and so these you have these scenarios, right? And you have to move them in some way, and the amount that you move them, so that is determined by the setup uncertainties. Yeah, so it's like if you have bigger uncertainties in photon therapy, you have a bigger PTV margin. In proton therapy, if you have more uncertainty, you move these scenarios more out. Is that an answer to your question?
Okay, thank you.
Okay.
Thank you. Thank you, Ben. We'll now have Dr. Tejpal Gupta talking about the clinical evidence.
Thank you, sir. Next is particle therapy, clinical application, opportunities, challenges, and evidence by sir.
Can I have the pointer? Thank you, Ben, for setting the stage for particle therapy. Can I have the pointer? Slide moves with this. So initially, I was going to talk only on one part of this, which is the challenges, but then Indranil has asked me to talk on the opportunities, the challenges, and the evidence for particle therapy. Doesn't move. Is this not working? Anyway, just see if that works. So the brief outline would be introduction to particle therapy, the physical and biological basis, clinical applications, and what are the challenges that we encounter when we apply proton beam therapy, the evidence map as of date, including ongoing and proposed randomized controlled trials, and future perspectives. So as we all know, when ionizing radiation traverses a material or medium, whether it is a charged particle or an uncharged particle, the deposited energy actually ionizes the material. And yeah, so for the most part, we'll concentrate on protons. As Ben said, they are the most commonly used form of particle beam therapy. But I have some references to other ions as well. So one of the problems with photon-based techniques is this unavoidable exit dose, whichever modality or whichever technology you use, the exit dose is unavoidable with any form of photon therapy, and that you can avoid to a large extent with the particle beams. This is just a brief mathematical sort of summary of interaction of charged particle with matter. You can see the Bragg peak there. I think Ben will have much more understanding, and the physicists in the audience. For me, this is just a pretty picture. Now, why particle therapy? Two reasons. One is, of course, the depth dose characteristics, so the physical depth dose characteristics. And the other is, of course, the radiobiology, or the RBE, which Ben also referred to generally for proton taken as universally as 1.1, although that may not necessarily be the right assumption. For carbon, it is even higher, between 2.5 to 3. Now, this physical sort of selectivity, the Bragg peak depositing or spreading out the Bragg peak within the tumor, and the biological effectiveness because of the enhanced RBE, which increases the ionization density and hence more damage to the tumor cells, and also reduces the influence of oxygenation, which is particularly more relevant in higher LET radiation, including carbon ion and helium. Now, some subtle differences between carbon versus proton. So if you see here, this is an 18 MV photon beam. In the green is the 125 MeV proton, and you can see carbon ion in the red there, the 254 and then the 300. And if you see, there is some, this is the Bragg peak, but there is some tailing there as far as the carbon ion is concerned. So carbon ions have a very high peak to plateau ratio. They have a better penumbra, but there is a fragment tail. And of course it has a higher RBE, but it comes at a much higher cost. The fragment tail is beyond the Bragg peak, and although they are of low physical dose, but they have relatively high RBE. And sometimes this fragment tail can extend up to 15 centimeters also, and the BED from this fragment tail is not negligible, and that's why in children it's generally not recommended to use carbon or helium. Now coming to some of the clinical applications, and if you sort of look at why would you want to use advanced technology including protons. So the sort of in radiotherapy we want to improve the local control and potentially improve survival and reduce acute and late radiation associated toxicity. So you have the probability of tumor control for a given dose and the probability of complications. So essentially the tumor control probability and the normal tissue complication probability curves, and our goal is to shift these curves as further apart as possible. So that's one of the sort of goals of radiotherapy, that you want to improve the therapeutic index of any treatment that you offer, and the further you can separate these two curves, the better would be the therapeutic index. Now, these are some of the classical indications of proton beam therapy, clinical indications, and mostly most countries and most sort of government policymakers divide them into two categories, group 1 or category 1 where it is medically necessary, and group 2 where potentially there may be a benefit of using proton beam therapy. This is somewhat old. I will come to the new Astro model policy which was published last year. But one thing that you can see that in most countries, including the US, the UK, the Italy, and for that matter even in the Denmark and the Netherlands and the Canada, some of the tumors such as chordoma, chondrosarcoma, pediatric tumors, brain tumors are category 1 or group 1 tumors, whereas some other tumors such as head and neck, thoracic, pelvic, and re-radiation, head and neck, paranasal sinus, they are in group 2 or category 2 tumors. But this is based not on any solid scientific evidence. This is sort of based on what the Astro looked at all the data of proton beam therapy published before, and who are most likely to benefit with that technology. Similarly, the Netherlands group and the Canadian group, all of those people have looked at who are the people who will most likely benefit with this technology. In the US, there has been an increasing use of proton therapy over time. This is data from the NCDB, and if you look at this is time point between 2004 to 2018, so there has been significantly increased use, and significantly most of that has been in children less than 15 years of age. But if you see here, this still constitutes only about 1.5% of all patients treated with radiotherapy. So less than 2% of all patients treated with radiotherapy receive proton beam therapy, even in the United States. The Astro model policy was updated last year, and in group 1 they have some general sort of recommendations. So children with benign or malignant tumors in less than 21 years of age, also curative intent re-radiation actually is in that category. And then they have some site-specific recommendations, so CNS tumors, head and neck, thoracic, abdominal, pelvic, and so on and so forth. So if we were to look sort of in a more tangible manner, what is the clinical benefit and how do you define the clinical benefit? So one way could be when you can improve the efficacy of treatment. So in cases where you can do dose escalation which can result in a better local control and potentially survival. So typical example would be radio-resistant tumors such as chordoma, sarcoma, where a higher dose is required and difficult or not very safe to deliver with standard photon technology. The second way to look at clinical benefit is a better safety. So if you can reduce dose to OARs, whether critical OARs or even not so critical OARs. So classical examples would be pediatric cancers, CNS tumors, head neck cancers, lung, prostate, breast, GI. And finally, both improved efficacy and safety. And the prototypical example of that would be curative intent re-radiation setting. So we could sort of measure clinical benefit in these terms, in improved efficacy, better safety, or combined improvements in efficacy and safety. So coming to dose escalation and efficacy of protons. So this is a systematic review and meta-analysis of particle beam therapy in skull-base chordoma and chondrosarcoma. And if you see that the local control rates and the 3-year and 5-year local control rates are actually in the 90s. With photon technology, they hover somewhere around the 60s. So clearly there is, compared to historical photon data, there is definitely improved local control. The survival data may not be so compelling, but certainly significantly improved local control as far as skull-base chordomas and chondrosarcomas are concerned. If you look at pediatric cancers and CNS tumors, I mean, there are a host of publications that look at pediatric cancers and CNS tumors. However, the sort of conclusion from those studies is also that, so this is actually a systematic review, essentially a health technology assessment done for Cancer Australia, where they looked at the evidence for pediatric cancers and CNS tumors, and for both, although they observed that with proton beam therapy there was less cognitive deficits for specific tumor types, but the quality of evidence was actually significantly poor. Similar things for the CNS tumors. So as I said, this was from a evidence snapshot for Cancer Australia when they decided to invest in proton technology. The snapshot is actually for all sites, but I just chose the pediatric cancer and the CNS tumor to highlight that although it is a given that most countries and most centers would treat children and pediatric brain tumors with proton beam therapy, the evidence base for that is not very, the clinical evidence base for that is not very compelling. Curative intent re-radiation, over the last decade or so, there has been an increasing use both with photons as well as with protons. This is to show an overview of particle re-radiation for some of the CNS tumors, including meningioma, ependymoma, and some head and neck cancers as well. So it has been increasingly used. This is for the head and neck cancers. What it does show that there is significantly reduced toxicity, and the control rates or the efficacy is comparable to historical photon-based re-radiation. So you don't, so you get similar local control rates, but you can reduce the acute and late toxicity quite significantly if you use proton re-radiation in the curative intent. We have been using a lot of photon-based re-radiation over the last 10-15 years. Increasingly, we now are doing a third course of radiation. This is in the last 7-8 years, we've done focal re-radiation in the CNS for around 9 patients. More recently, we've shifted them all to proton-based re-radiation since we started proton at our center right now. So this is an example of a proton-based third course of radiation, local radiation. Mind you, this is not a separate site. I mean, this child has had radiation 2 times before in a posterior foci ependymoma and had another local recurrence for which we are now treating the third course of RT. So what it does is it provides us increasing confidence in the way we are delivering our treatments. And I think in the last 1 year, this is the third child that we have done the third course of radiation on protons. So previously, the data that I showed you of the 9 patients was with photon over the last 7-8 years. In the last 1 year, all the third course of radiation that we have done is with protons in 3 children. What are the challenges that we encounter? Of course, there are a lot of uncertainties in proton planning and delivery. Ben alluded to it. I mean, we see these pretty pictures all the time, but does the patient receive what is seen on the treatment planning computer? And that answer may not always necessarily be yes. There are uncertainties in proton planning and delivery. Some of these are planning uncertainties, so in the patient itself, so metal artifacts, your image quality, the stopping power ratio, some tissue-dependent biological parameters, and some uncertainties in the dose calculation model, the beam model, the tissue heterogeneities, the biological models that we use. So everything is not so crystal clear. I mean, there are uncertainties, and these uncertainties have to be taken into account when you do proton-based planning. The RBE models in treatment planning, as Ben mentioned, a constant RBE of 1.1 is sort of used in all commercially available treatment planning systems. There are known RBE variations. There is end of range uncertainty. For carbon ion, a variable RBE scheme is used, but for protons, for the most part, 1.1, a constant RBE is used, and we all know that that's not necessarily always the case. So towards the end of range, the RBE is probably much higher than 1.1. So these planning uncertainties are also there. In addition, there are delivery uncertainties, both interfractional anatomical changes, which can perturb the dose distribution, as well as intrafractional anatomical changes, particularly in moving targets. So you have planning uncertainties, you have delivery uncertainties. Not that these don't exist in photon-based technology, but they do exist even in proton-based technology. Now, how do you mitigate some of these uncertainties? So range uncertainties, the use of dual energy CT, it provides for improved calculation of the stopping power ratio. Again, some formula which Ben can understand and explain better. But if you look at the difference between single energy planning CT and a dual energy planning CT, typically the range difference is of the order of 1.5%. So, I mean, the single energy CT, you would get a range uncertainty of between 2 to 3.5%. If you use a dual energy CT, you can bring that down to around 1%. So, some improvement in the range uncertainty with the dual energy CT. What about safety margins? So typically you would use safety margins. Non-isotropic can be used. Most people use robust optimization, which sort of accounts for setup error as well as range uncertainty. Also, you can optimize the beam angles and the direction. So one of the ways to sort of do it is not to sort of stop your beam abutting an OAR. That's not the recommended thing to do. So to prevent or to reduce the range uncertainty in RBE at the distal edge of the beam. So the beam angle optimization is also an important aspect of trying to mitigate certain uncertainties in proton planning. As Ben also mentioned, a robust optimization, this accounts for uncertainties both in the patient setup, range, as well as biology. So typically for brain and even for head and neck, we use a 3 millimeter setup uncertainty and a 3.5% range uncertainty. Presently, we are using a single energy CT. Our dual energy CT, when it gets installed and commissioned, then we'll probably bring down the range uncertainty to 1 to 1.5%. But currently we use 3 millimeter setup error or uncertainty, and we use 3.5% range uncertainty to look at robust optimization. Coming to the last bit, which is the evidence map. So if you look at any new technology and what are the sort of correlated outcomes of interest. So of course technical performance of that technology, the feasibility, the safety, and the clinical efficacy. And all of these are important. Sometimes one is more important than the other, but I think the attributes of technical performance, feasibility, safety, as well as clinical efficacy, all of them are some of the attributes that need to be looked at when we look at any technology, new technology that comes up for clinical use. This is just to show the hierarchy of evidence as far as protons are concerned. So it all started with dosimetric comparisons, and then retrospective cohort studies, prospective cohort studies, matched pair analysis, systematic review of non-randomized data, randomized controlled trials, far and few in between. And of course, till now we don't have a systematic review or meta-analysis of randomized controlled trials because they are far and few. So dosimetric comparison, I think there are compelling differences, and most people use some of these sort of pictures to show how much extra dose goes with photons compared to protons, and this cannot be denied. I mean, this is there, this is what really happens inside the patient. With proton, you can reduce that low dose spillage quite significantly, and that can have implications in terms of your normal tissue complications. So this is here just showing the hippocampal dose, and as you can see here, I mean, this you are sparing that left hippocampus, which is getting sort of significant dose in the photon plan, and from 11% risk of sort of complication to 66% risk, or reducing the risk of complication from 66% to 11%. So the dosimetric difference and the OAR doses, I think that's very compelling. There is no debate on that. Some retrospective cohort comparison. So this is proton versus photon radiotherapy for CNS tumors, as I primarily deal with CNS tumors. A systematic review of the dosimetric comparison. So this is target conformity and homogeneity. So actually it favors for the most part the homogeneity. The conformity actually favors the photons, the homogeneity is favoring the protons. But more importantly, if you look at the OAR doses, and this is for almost every single OAR that was looked at, statistically significant reduction in doses to almost all the OARs with protons. Now, how much of that translates into meaningful clinical benefit remains a question that needs to be answered. Looking at effectiveness and safety of proton beam therapy, this is another systematic review, how proton fits into the management of adult intracranial tumors. And more recently, we were involved in this article regarding controversies in neuro-oncology, focal proton versus photon radiotherapy for adult brain tumors. Some evidence for better preservation of neurocognitive and endocrine function with some degree of reduced risk of second malignant neoplasm, but overall we all agree and acknowledge that the quality of evidence is low even for brain tumors. This is a matched pair analysis from the National Cancer Database for gliomas, and what it does show, just like Ben showed for head and neck cancers from the Taiwan registry, that there is a suggestion of improvement in progression-free survival and overall survival. I am very, very skeptical of this data, despite it being a matched pair analysis. I don't think there is any shred of evidence to suggest that for the same dose that you give, you get a better progression-free survival as far as gliomas is concerned. This is matched pair analysis of second malignant neoplasm for patients first treated with protons at the MGH and with photons from the SEER database. This does show statistically significant reduction in induction of second malignant neoplasm with protons with a hazard ratio of 0.52. So there is evidence to suggest that the second malignant neoplasm can actually be lesser when you use protons as compared to photons. What about neurocognitive outcomes? This is again comparative data of photon versus proton, looking at neurocognitive function in medulloblastoma, and for the most part you would see that for most domains of neurocognitive function, excepting non-verbal memory, it favors the proton arm. There is better preservation of neurocognitive function with proton. Now coming to the randomized controlled trials, and there are some 5 or 6 of them. So this was one of the first publications comparing protons versus photons for non-small cell lung cancer, and it was a negative study. It was a single institutional MD Anderson study. Did not show any significant reduction in radiation pneumonitis, or for that matter local failure. So there was no difference in outcomes between proton and photon, and more recently it was sort of updated at ASTRO 2024, again at long-term outcomes also show no significant difference in either toxicity or efficacy. Another trial that looked at proton versus photon in esophageal cancer, the progression-free survival and overall survival were comparable, and so was the quality of life. There was no significant difference in PFS, OS, radiation pneumonitis, or quality of life between protons and photons. This was published a few years ago. 3 years ago, there was this publication again from MD Anderson looking at proton versus photon in glioblastoma, newly diagnosed. Their primary endpoint was time to neurocognitive deterioration. Unfortunately, did not show any difference between proton versus photon in time to neurocognitive deterioration. PFS and OS were no different between proton versus photon. Although there was some suggestion that there was reduced radiation-induced lymphopenia in newly diagnosed glioblastoma, my personal take is that most of the lymphopenia in newly diagnosed glioblastoma comes from temozolomide and not from the radiation. So I really don't buy that argument and logic that radiation-induced lymphopenia could be used as an indication for using proton for a newly diagnosed glioblastoma. There was some lesser fatigue with protons, but that's not a very critical side effect of treatment. One of the randomized trials which compared proton CSI versus photon involved field radiotherapy in leptomeningeal disease. Again, I think very unfair comparison. So solid cancers with leptomeningeal disease, they were treated with either randomized to proton-based CSI versus involved field radiotherapy with photons, and not very surprisingly, the CNS progression-free survival as well as the overall survival was better with proton CSI. Does not necessarily mean that you would not achieve the same with photon CSI. I think this was not a fair comparison, and this was touted as a landmark trial sort of establishing the efficacy of protons over photons, but mind you, the comparison is CSI versus IFRT in leptomeningeal disease, and that's a very unfair comparison. Two recent presentations last year, this year ASTRO. Phase 3 randomized trial of IMPT versus IMRT for head and neck cancers. Ben showed you the Taiwan 950 patients matched pair analysis. This was in oropharyngeal carcinoma, 400 odd patients randomized. There was no difference in outcomes in terms of, so this trial, the primary endpoint was actually, it was a non-inferiority design with a primary endpoint of progression-free survival at 3 years. I really can't understand why you would do a non-inferiority design for progression-free survival for a technology which is 10 times more expensive. They should have done a superiority design with an appropriate endpoint. So the conclusion was that IMPT is non-inferior to IMRT, which is not the right way to look at it. Of course, it is non-inferior in terms of progression-free survival, local control, overall survival. But whether it is superior in terms of reducing xerostomia, dysphagia, acute, late, that is what is more important rather than that it is non-inferior in terms of local control, progression-free survival, or overall survival. Another randomized trial that was presented at ASTRO last year was the PARTY-QOL, which is a phase 3 randomized trial of proton IMPT versus IMRT for localized prostate cancer. This presentation looked at the quality of life, and again around 450 patients randomized. No significant difference in quality of life between proton versus photon. So if there is no significant difference in quality of life, why would you pay much more for protons? Now, this is a busy slide showing some of the ongoing randomized trials. Some of them actually, the head and neck trial and the PARTY-QOL probably have been presented. So this includes them, but this is a whole lot of randomized trials that are ongoing currently. The UK approach is one that I like. They have taken an approach of when they started on their proton program, they decided to develop high quality evidence through randomized controlled trials, and their national infrastructure for proton beam therapy actually supports the conduct of these trials. Originally 3 randomized trials, the torpedo, the parable, and the approach. The torpedo in oropharyngeal cancer, the parable in breast cancer, and the approach in IDH mutant grade 2-3 oligodendrogliomas were planned, but over the last 3-4 years, they now have added several other sites where they are doing randomized trials, particularly mesothelioma, hepatocellular carcinoma, and some of the trials are in planning phase, and in the next 5 to 10 years, I think a lot of good quality data should emerge from these trials that are being planned and being done in the UK. At our institution, I am talking about CNS tumors because I practice neuro-oncology. All other sites are also planning and developing protocols for randomized controlled trials. We have decided to invest our resources in neuro-oncology in 2 randomized trials, one in medulloblastoma. It's called the PRIME trial, where standard risk medulloblastoma get randomized in a 1:1 ratio to photon-based CSI plus boost versus the proton-based CSI plus boost with serial longitudinal follow-up and assessment. The primary endpoint is a composite endpoint of qualified overall survival, which looks at neurocognitive neuroendocrine failure, but also at progression-free survival, brainstem necrosis, and overall survival. In similar manner, there's another randomized trial, which is the PRIDE trial, which is in children and young adults with benign and low-grade brain tumors planned for curative intent RT. They get randomized in a ratio of 2:1 in favor of protons to IMRT versus IMPT. And again, they will be followed up periodically with serial longitudinal assessments looking at neurocognitive and neuroendocrine function. All is fine, but there are several barriers to clinical trial participation in protons, and this is not unique to India. This is across the globe. I think there are several barriers, and many of those barriers have something to do with lack of motivation, uncertainty, insufficient knowledge. Proton centers are sometimes away from the main cancer center, so safety and familiarity of environment, and there's a lot of distress in patients, and all of these compound issues and pose barriers to participation in clinical trials. There have been a host of cost-effective analysis for protons. This is a systematic review of cost-effectiveness studies in proton radiotherapy. What the authors concluded was that with limited data, proton beam therapy offers promising cost-effectiveness for pediatric brain tumors, well-selected breast cancers, loco-regionally advanced NSCLC, and high-risk head and neck cancers. But again, since the evidence base itself is weak, I think these cost-effectiveness analysis and all also are on weak or shaky grounds. Of course, there is significant variability in such analysis based on the context, the disease setting, and the model assumptions or the modeling that is done for such analysis. This is a recent publication for primary brain tumors in Sweden, and if you look at the incremental cost effectiveness ratio, protons are not necessarily always more cost effective than photons. I mean, we assume most of the time that they are in the long run at 10 years, 20 years, given the mitigation of late toxicity in children and young adults, they would be more cost effective, but that's not necessarily always the case, and this is an example from an analysis done more recently in Sweden. Some of the future perspectives, there are a lot of areas for research areas in particle radiobiology, and that includes in terms of in aspects of beam delivery, also in modeling, looking at newer ions, and of course looking at flash therapy and spatially fractionated radiotherapy as far as protons is concerned. Arc therapy is another technology that is sort of coming up, particle arc therapy, being touted as the next gen technology as far as protons is concerned. But there is a balancing game there, and you have to the PAT optimization is much more complex than the fixed field optimization that currently is available on commercial treatment planning systems. So in summary, particle therapy, particularly protons, are here to stay. I don't think we can wish them away. There are distinct physical and biological advantages compared to photons. The dosimetric improvements are compelling and unambiguous, and I don't think anybody can argue on that. However, they do pose new and unique challenges as well as provide opportunities. Particle beam therapy, including protons, requires huge investment, both initial as well as running costs. So it's not only the initial investment, even maintaining proton facilities quite costly. It is associated with a steep learning curve. Still, there are more unknowns than knowns in proton radiobiology. For the photon radiobiology is very well defined, characterized, and known for the last more than 100 years. And although the protons have been there for 50 years, I think there are more unknowns than knowns as far as proton radiobiology is concerned. The clinical evidence base is of low quality, but fortunately it is rapidly emerging, evolving, and growing through the conduct of randomized controlled trials. There exist significant barriers to patient participation in proton clinical trials. Apart from the cost, there are other issues which sort of preclude clinical trial participation as far as protons are concerned. And there is a need for properly designed, well-powered trials with appropriate endpoints, and not necessarily using a non-inferiority design or comparing photon IFRT versus proton CSI. So I think the comparisons have to be fair. Even if you do a randomized trial, it has to be a fair comparison. And results of these ongoing RCTs might potentially change practice in the future. As of now, there is no strong evidence base to support the use of protons in clinical practice. Thank you for your kind attention, and I'm happy to take questions.
This is for Dr. Tejpal.
Thank you very much for a very nice presentation. I have two questions, if I may. First is about this non-inferiority trial that you talked about. I think, maybe I'm wrong, but I think it's not a given that there is non-inferiority. If you look at the planning challenges, I mean, it may also go wrong, right? So that if you don't do it well, you lose control probably. So is that a valid argument for this study, or?
So most of the time non-inferiority designs are done for either cheaper alternatives or so you set a non-inferiority margin. The delta that was set for that trial was 1.3, I mean the hazard ratio was 1.31, which means if it was up to 30% inferior progression-free survival, that would still, the 95%, the upper limit of the 95%, if the hazard ratio went to 1.3, still it would be considered as non-inferior progression-free survival. For I mean, I get your point that if you don't do your proton planning well, you could actually land up with worse local control. But from the previous experience as far as passively scattered, and for that matter even with IMPT for head and neck cancers, I don't think there is any such evidence that we are afraid that it is going to be inferior. I don't think when MD Anderson folks designed it, they thought they were looking at, oh, maybe the local control will be worse. I really don't think, as clinicians, most of us don't think that the local control would be worse. We are now using robust optimization. A lot of effort goes in the planning. Of course, there are uncertainties and you never know what comes out. If your argument was to be taken into account, I would actually do a dual hypothesis design where you look at non-inferiority for the efficacy or the local control, as well as look at superiority for the toxicity outcomes.
Thank you. Can I have another one? Yeah, so your first conclusion, I found it interesting. So protons are here to stay. Well, there's a lot of concrete, so probably they will not disappear easily. But my question would be, based on the evidence that there is, do you expect substantial expansion of proton therapy on the short term?
So if you talk about low middle income country setting, probably not. If you talk about high income country setting, I think there is already quite a bit of expansion. I am made to understand that China has ordered more than 120 proton machines, not the 3 gantry solution, the single gantry solution, which is at a much lesser cost and a much lesser footprint. So if the cost comes down substantially, I do see a rapid uptake of the proton technology.
But is that also what you would recommend based on your observations of evidence?
Not necessarily. I don't think at this point in time, with evidence base being very weak, I think you have to really look hard and think hard before you invest in a proton facility.
Nice for research, right? It's very nice for research to do.
So you generate evidence and say that yes, it is useful or just not worth pursuing.
Yeah. Thank you.
Hello, sir. My question is related with CT simulation. What are the markers or the fiducial markers we use in proton therapy?
So we use the same set of fiducial markers in proton therapy. It is no different. It's not different from the photon markers.
CT simulation done in same way or it's different?
There is, so it's very similar. It's just that the immobilization and the base plates and all that are a bit different from the photon. So you have to prevent, so based on where the beam will enter, the thermoplastic masks and all are specifically designed for proton technology.
A fiducial we have placed in CT simulation at same place or it's different?
No, it's the same. I mean, the process of CT simulation I think is pretty similar.
Fiducial
I don't know if
outside the body or
I didn't get you.
Fiducial, we put fiducial during CT simulation is put outside on orbit or put on the body.
No, if it, so like head, neck and CNS, we put it on the thermoplastic. Prakash, you want to make?
Maybe you want to ask about the density variation
On the,
due to the
please speak in the
fiducial
mic,
and all.
Prakash, people can't hear you.
Maybe she is asking due to the density variation of the fiducial in the treatment. What we are doing, we are putting at the same place like photon, but we are overriding it with the air. It should not more pressed or like it is on the surface, but during planning we override it with the air density so that it should not impact the proton beam.
Sir, one more question. What is the difference between a dual CT and the spectral CT? Please give.
So dual energy CTs are of two types. You can have dual detectors, or you can have dual kV sources, and they give you a more precise stopping power estimation, and that's why the range uncertainty can be brought down. Currently, most commercially available treatment planning systems use a range uncertainty of 3.5%. I showed you a single energy CT. Actually it varies, the range uncertainty varies from 2 to 3.5%, but if you use a dual energy CT, that range uncertainty you can bring down to 1%. So the uncertainty reduces if you use a dual energy CT for proton planning, because it more accurately estimates the stopping power ratio of protons.
Thank you, sir.
So Tejpal, we are, protons, very exciting for us in radiation oncology. Dosimetrically it's so much better. Why do you think that in randomized control trials we are not getting benefit?
I think the first part to that, the first answer to that is that I think the randomized trials have not been, I would say, properly designed, or the most appropriate endpoint, or the design has not been the best. Another aspect is especially the lung and the esophagus trial. They were largely passively scattered beams. They were not IMPT. The current generation of both esophagus and lung trials are using IMPT, and possibly you might see some benefit. I think randomized control trials are as good, or provide as good evidence as their design and conduct. So if you don't use the proper design, if you don't use the most meaningful and appropriate endpoint, you might end up, the head and neck trial actually concludes that it is non-inferior and should be considered standard of care. How many people in the audience would consider replacing photon with proton based on non-inferiority for local control?
I think the non-inferiority design is more of a practical consideration or something like that in trial design. But even without IMPT, you're looking at the lung, which is a parallel structure. Why is it that?
So I think there is a lot of unknown about the radiobiology in the RBE. So particularly for esophagus and lung, I think what was estimated as the sort of damage to the lung was a lower estimate than actually what happened, and probably that has to do something with the radiobiology of protons. We don't really understand the radiobiology of protons as well as we understand for photons.
Drew, do you have a viewpoint on why the lung trial and the esophagus trial?
Yeah, I think that was mentioned. The current rates of high-grade pneumonitis are on the order of 3 or 4 or 5% now in most modern clinical trials, and so designing a trial to detect an improvement in that sort of endpoint would require thousands of patients, realistically, for that event rate to change in a measurable way, in a statistically significant way. And so I think if you're looking at purely a toxicity reduction approach for thoracic treatment, you're going to be outcompeted by the tumor failure rates. Our lung cancer control rates are much, much worse than 4%. So I think that the competing risk is going to dominate in most situations when you design those trials. So I think it's a very tough endpoint. I very much appreciate, we had this discussion for breakfast actually. The problem with the head and neck trial is that the endpoint, showing equivalency, they then looked at their secondary endpoints as a way to drive their message. They thought that the fact that there was a G-tube reduction and a rate of toxicity, acute toxicity reduction, was enough to justify that change, given that there was no change in tumor control. But I completely agree that isn't really the way we justify spending millions and millions of dollars on new equipment, and in some cases charging patients triple or quadruple the cost. It's just not sustainable for even large healthcare, high cost environments.
I'm not so sure about the reduction in acute toxicity with protons for head and neck cancers. In fact, I think more centers have burned their fingers with skin toxicity when they initially started out. It's worse than photons if you really don't take care of the skin, right? You can actually have worse skin toxicity. Even mucosal toxicity, I understand, is not so trivial with protons. I haven't personally treated head and neck cancers with protons, but what I understand from my colleagues who've treated, the acute toxicity is not very significantly different.
No, I think I was commenting on the Anderson abstract where they use those G-tube and acute toxicity endpoints.
So the late toxicity, there might be some benefit in late xerostomia and late G-tube dependence. That is quite possible. The acute toxicity, I am not so sure.
Yeah, agree.
Yeah, I would like to react, maybe two things, but I mean, about your question, Indranil. The dose distributions are so much better. I think that is often for the low doses and maybe the intermediate doses, but not always so much for the high doses. And so you can also with the randomized trials, then it will be not easy to show difference, right? And I mean, then about this lung trial, I think I saw some follow-up studies where I mean, it's quite detailed studies, and what I remembered from those studies that, I mean, there was significant sparing of the lung, but it were the wrong areas. I don't remember anymore how they determined that, but so it's quite a detailed study, quite a nice study I remember some time ago.
So what I understand that in clinical scenario, in proton therapy, we are using photon equivalent doses. Am I right?
So the TPS actually already, so we prescribe, so like for meningioma or craniopharyngioma, we'll give 54 gray and 30 fraction, just like you would do for photon. But the research treatment planning system actually uses the RB, it's already sort of weighted in. So
so my question is that, I mean, because of higher RB, we are giving photon equivalent doses. So where we are then getting the advantage of higher RB?
So as I said, the RBE is uncertain. We have assumed a constant RBE of 1.1. For tumors which are relatively radio resistant and it is not easy to give 70, 74, 78 gray like skull base or sacral chordomas, there I think you stand to gain with protons because you can deliver that dose. But I get your point. You're saying if you are giving the same photon equivalent dose, then how are you
getting the advantage of higher?
So that's why the local control paradigm is, unless you dose escalate, it's unlikely that you will get a better local control. Unfortunately, for the most part, for most studies, even in photon, if you look at head and neck beyond 70 gray or for gliomas beyond GBM beyond 60 gray, the dose escalations have not really improved local control and progression-free survival. But I get your point when you say that
it's not only the physical dose escalation. When you have higher RB, you know, there is maybe something.
So if you look at the earlier literature, particularly I can talk about medulloblastoma, where there was concern that based on with protons, there was actually a higher incidence of brainstem necrosis, and actually Astro had to come out with a white paper on trying to reduce brainstem doses in proton therapy for medulloblastoma. Currently, I think everybody is cognizant of that, and the rates of brainstem injury with proton and photon are very negligible. I mean, it's comparable to the photon world, but in the initial phase, there was actually seen that the brainstem necrosis were higher, particularly because the beams were abutting the brainstem in the boost part. So if you abut beams in any OAR, that's not the recommended thing to do. So now nobody abuts, the beam doesn't end on the OAR. It will sort of pass parallel to the OAR. So there are, people have learned over a period of time, and I think most physicists who plan them are aware of some of these nuances.
Supriya, you wanted to say?
Ben, you are absolutely right that high doses don't change, right? And it is the volume effect. And coming to the question of clinical trials, so in GYN we have built NTCP model, and it is now based not on delta NTCP CTCAE, but on persistence and length of toxicity, and also taking into account patient symptom weightage. So we are never going to be in a situation where you'll show reduction in grade 2 or 3 toxicity with protons. And if the utilization has to be built, it has to be with patient survivorship and these low grade symptoms. And I heard Tejpal speaking about fatigue. So in PARSER trial, when we did in IMRT versus 3D CRT, it did not go unnoticed that maximum difference came for fatigue. And when you see longitudinal quality of life scorings of patients world over, even in GYN studies, patients report maximum impact of fatigue on their quality of life. So there are a lot of soft symptoms, I think, that need to be addressed, and we are just chasing these grade 2, grade 3.
Yeah, but Supriya, just, philosophically, could you convince somebody to take protons instead of photons for less fatigue? Do you think that that's a good endpoint?
So we have built this model putting all these toxicities, and we are going to offer on delta NTCP for cumulative toxicity, which includes all these symptoms.
You are offering that on a clinical trial. He's asking if there is less fatigue, would that sort of, would somebody be willing to fund that, or insurance would be
No, it is not only on fatigue, it's on cumulative symptoms, and this is clinical trial, and clinical trials will give results. If it's positive, it will go, right? Right now, most of the way we are offering protons, I think the level of evidence is anyway less.
I think from the community treatment perspective, we do face a problem, right? Like, one of the main challenges, I'm sure we'll discuss it when Jyotirup speaks about designing clinical trials for advanced technology. But once you've already bought the stuff, it's really challenging, isn't it, to then not use it. So the hospital which has bought the MR-Linac, which has bought the proton therapy, how is it going to tell people that, that we don't know of any benefit? So, and not all hospitals are research hospitals, so it's a challenge.
Can I have a small question? I'm a physicist, so I don't know, but that could be relevant, at least for me to understand. So this fatigue, is that a long lasting, or does that disappear, or?
So I started with fatigue, but let me come back to GI toxicity. So when you compare, for example, I'm still not going to proton, 3D CRT and IMRT, what we've learned is that a grade 2 toxicity happening to patient of 3D CRT is not same as grade 2 toxicity in IMRT, because when patients get treated with IMRT, when they have grade 2 toxicity, it lasts for a smaller period than in a patient who has 3D CRT and develops. So there is clearly a volume effect into toxicity for their persistence. So what I'm trying to say is that the entire benefit of protons will come from reduced volumes of irradiation and not only high dose. So we should be looking into cumulative toxicities, and right now all proton trial designs are on grade 2, grade 3 toxicities. So they will fail miserably.
So Ben, for CNS tumors, I mean the glioblastoma trial, the fatigue is actually transient. It sort of disappears after the radiation is over within a few weeks.
Can I make a point? Stage one, other factor I think which may contribute to the outcome is how much is the PTV margin you keep in protons versus photons? Is it same?
No. So the concept of PTV is not now commonly used as far as protons is concerned. Ben also showed and I also showed, we use robust optimization. So we actually plan on the CTV, the final CTV,
Yeah.
but the robust optimization includes for say CNS, we are using a 3 millimeter setup margin in the robust optimization. So the system calculates those setup errors, it simulates those setup errors and
still-
provides a plan that would cover all those scenarios.
But still, robust optimization also you have different limits. So you can have 3 millimeter, 5 millimeter.
Yeah. So
depending
based on your
system
sort of judgment of
and-
setup
yeah,
error, you
yeah.
would give. So for CNS, we use 3 millimeter. Prakash, for head and neck also it is 3 millimeter?
Yeah.
3 millimeter.
So I think a lot of things are dependent on clinician, his own contouring and his vision
So,
of
sir,
PTV margins and other
between
things.
photon and proton, I don't think there is any difference as
Yes.
far as contours are concerned. I mean, most of us would contour it pretty much the same way.
Benefit we may not get if these things are not very different. Second thing I want to ask about is the imaging quality. We all know it.
It's not as great as at least in the IBA systems that we have. I mean, it is decent. It's actually from Varian, but the software for the cone beam is not from Varian. So
how is the image quality compared to the say for example?
it is
Varian?
inferior. It's inferior to the photon world.
So I think some amount of benefit may go away because of the imaging.
But
so I think these are the variable factors. That's why.
But we have to also understand that there was no cone beam CT in IMPT till very recently. So it's an advancement, but certainly the cone beam quality has to be much better if you have to sort of rely on it.
Yeah.
Anjali, do you want to quickly summarize?
I think everybody is hungry.
So very shortly, first of all, this session started with Dr. Ben letting us know about the radiophysical as well as the radiobiological aspects of particle therapy, to be precise, proton therapy. And thereafter, of course, Dr. Tejpal has very nicely elucidated to the clinical aspects of proton therapy at large. Dr. Ben also told us about that planning is very important, robustness of planning is important, and there are uncertainties to the planning aspects which we need to take into account. And Dr. Tejpal, of course, told us the indications of the proton beams. There were certain indications that were there, and there were certain probable indications as well. And you could touch upon the indications as model-based indications as well. So apart from all the discussions that has taken place, and we have got to get a larger aspect of what proton does and how we are treating patients with protons, I would like to ask Dr. Tejpal in particular that you have a large experience with CSI and of course pediatric patients. So for your pediatric patients, what is the hard dose that is actually given in proton therapy versus photon therapy? As well as, are you counseling those patients for the late effects the same way? Because, of course, fertility and all, are you still counseling? Are the dose to the genitalia and all the same? How much relevant is your counseling?
So we started protons last year in August, now close to 1 year, 3 months. For the first 1 year, we did not treat any CSI patient, only I think in September we started with the first CSI patient. The planning process, I think the dose to the heart, the esophagus and all is much lesser. We still, I mean, you can't say that there will be no dose. So, but even with photon-based techniques, I don't think we have really had the VMAT and the CSI on tomotherapy. We've not really had very significant late complications as far as medullos and CSI is concerned. Of course, neurocognitive and neuroendocrine are there, but not so much cardiopulmonary toxicities. But we do still talk about all the late effects, including infertility. The infertility more from the cranial, the pituitary irradiation rather than the gonad irradiation. I think the experience with CSI is at this point in time very limited. We've just treated one patient who completed treatment, the second patient currently under planning, and a couple of patients lined up. I think as we go forward, as we gain more confidence, it was a conscious decision not to do CSI. Every month we had at least 2 or 3 patients whom we turned away, who had come specifically for proton CSI, but we just wanted to be first sort of comfortable with the technology ourselves before we started CSI.
Any other question from the audience? So, of course, proton therapy is very precise and has less probabilities of toxicity. With this, I think we can close the session, and we can break for lunch. Thereafter, we'll be coming back. Yeah.